Always the same question. If we compare results, if we compare different facelift techniques, we're used to only look at the result and not at the bad side, the complications, the morbidity. And we want this balance. We want a good balance between risk and benefit. So nowadays, it's like an artist. We have a whole panel of all kinds of techniques. Like the artist, the painter has all kinds of colors to make his painting. And the art is to choose the right combinations. And the magic word is synergy. Sometimes, if you combine 1, 2, 3 things, the result is not 3, but 6, 8, or 10. And we have to get rid of that reflex facial. If somebody comes for facial rejuvenation, do a facelift and a blepharoplasty, and that's it. What is the ultimate goal of aesthetic surgery? It's a happy patient. So it's not done to suggest patients what they need. A patient consulting for aesthetic surgery is not a sick patient. They don't need anything. They want something. And for instance, what should you do with her? What does she need? Well, she doesn't need anything. What will this patient make happy? It's a rhinoplasty. So you could do all kinds of other things. You could do a temporal lift. You could do a blepharoplasty. But she doesn't want this. She just wants a rhinoplasty, and look, she looks happier. Another patient. What will make this patient happy? It's hard to see from the frontal view. It's a liposuction. It's the only thing she needs. And here we see the nice OG curve just with the liposuction of the neck and the jaws. What will make this patient happy? Will we correct the acne scars on her cheek? No, it's a Muslim patient who wants to have a more westernized look, and it's a rhinoplasty. And of course, this man wants to look better, but does he need a facelift? No. He had a rhinoplasty. We filled his nasolabial grooves with fat, and we did a lower and upper blepharoplasty and with transposition of the fat in the lower. And actually, nowadays, I think he needs some more fat on his malar and in his lower eyelid, and he's scheduled for this. And that's it. So our workhorse, nevertheless, in facial rejuvenation is the max lift, the minimal access cranial suspension lift. We published this 2002. So this is what we do if we look into the skin. This is a patient we operated in the first book. We usually start with a liposuction, remove the fat between the platysma and the skin, and then we introduce 1, 2, or 3 sutures. The first suture will be the anchor to the deep temporal fascia. We'll go down and we'll lift the lateral part of the platysma and will have an effect on the cervicomentral angle. Then the second suture goes more oblique and will lift the jaw vertically. A little bit the same as the same principle of what Belittle explains. It's very simple. So we weave the suture into this mass without undermining this mass. And then the third suture, the anchor point is just lateral to the lateral orbital rim, deep temporal fascia. We'll lift the malar fat pad and we'll have an effect on the nasolabial fold, on the midface, and on the lower eyelid. And the effects you can see on the morphing. You can see the effect on the neck, the effect of the first suture. You can see the effect of the second suture on the jawline, on the definition of the mandibular angle, of the mandibular border, and on the marionette groove. And you can see the effect on the midface, the third suture, with an effect on the nasolabial fold, and on the midface, and a shortening of the vertical height of the lower eyelid. Why is the max lift different from a traditional facelift? Well, first of all, there's a pure vertical vector, shorter incision, limited undermining, no smash dissection, and no platysma dissection, and a powerful midface lift and a lower eyelid correction. Most important is, it is not a traditional facelift with a short scar. There are some different vectors. As Dr. Nahai said, the purpose of an incision is to gain access under the skin, to resect skin, or to redrape skin, in other words of Tom Dix. And nowadays, a facelift has evolved from a tightening procedure towards a subcutaneous sculpturing and redraping procedure. This is what people do when they come into your office. Younger people from between 40 and 50, they put their fingers at the mandibular angle and put it upwards. All the people include the midface and do this kind of maneuver. Nobody comes into your office and does this kind of maneuver, although all the facelift techniques are often this kind of procedure. Now do this little experiment, take a patient, put him on his head, take a picture, and put the picture upside down, and you will see that what a rejuvenation you get simply by inverting the gravity forces. And you see all these marking points, all these landmarks are just moved vertically. And you also see an augmentation effect in the zygomatic area just by inversing the forces of gravity. And this is what we will try to get with our suspension sutures. And we will have this kind of result, we will be very happy. And of course, there is some excess skin here and there that we have to deal with. So this is the incision, zigzag here, I will explain why, then the undermining, and 1, 2, or 3 sutures. And this is the principle. It's a kind of multiple micro imbrications we make in the subcutaneous tissue without undermining the mass. The anchor points are in a safe zone with regard to the frontal branch of the facial nerve. Skin redraping is not lateral as we used to do. We will get a dog ear here. It is vertical, and then you will have a little dog ear here that is easy to correct. Skin resection is here. Earlobe is put back, and the final scar is about 8-9 centimeters. The vectors are almost vertical. What about suspension sutures? The problem is it's foreign material, and many people say they cheese wire, so they will cause relapse. Well, the solution is to use resorbable suture, and we know that sutures cheese wire through soft tissue, but when you undermine, redrape, and resect the skin in the same direction, this maneuver will act as a lock on the subcutaneous microimbrication result. So this purslane is not a cable suture from one point to the other. It's a facial sculpturing procedure by multiple microimbrications. The skin redraping and resection is pure vertical, so this locks the microimbrication result. And here you see in life a situation. This is the zigzag incision that we do. This is done to, you also see that the knife is inclined to almost tangential direction. And this is the placement of the sutures. The first suture goes down, and then this is the platysma. You see, you want to be sure, you want to 2 or 3 bites into that platysma to be sure that you lift that muscle upwards. And if you pull on the suture, you see the correction of what happens in the neck. Second suture goes more oblique, more anteriorly, and this is just weaving into the mass. The bites are about half a centimeter deep. It's safe with regard to the facial nerve. And this is about lifetime surgery. It doesn't take longer than this. And normally this is done in the local. Like in this patient, she is awake, she has a little bit sedation with midazolam intramuscular, and that's enough. And this surgery normally takes between 1.5 and 2.5 hours, and that's finished. So we have plenty of time to do more things, like or combine surgeries, or add things like microfat grafting, as I will explain later. Now, this second suture is the knot is thrown at the maximum tension. You cannot overcorrect with this. And then the third suture goes from an anchor point just lateral to the lateral orbital rim at the level of the canthus, goes down to a point about 2 centimeters below the canthus, and goes then back upwards. And this suture will just lift the malar fat pad, and you will have a mid-face lifting effect, as I will show, in a very safe. And if you pull on the suture, nothing really happens. But if you simulate a standing position, you see that what happens. Now, skin redraping is pure vertical. If you redrape laterally, you will have a dog ear here. This is what happens if you redrape vertical, and this is just redraping. There is no tension. So this is, we mark what is in excess, and this is the amount of skin that is resected. And then we do this kind of suturing with a U-shaped running suture. This is another thing. Because of the vertical redrapement, the the neck skin comes into the face, and this skin is thinned by the liposuction, and the mandibular border is covered with thin skin, so that will improve the mandibular definition. We do simple max, that means with 2 pursing sutures for isolated neck and jaw problems, or for when the patient prefers this, when she wants very simple surgery. So this is done in the local 1.5 hour surgery. This is for younger people. The neck is cleaned up. She had an upper bleph, and see also the change from a more vertical to a more oval shape. And this is very simple and safe surgery, 3-quart view. Or another patient with a more heavy neck, so more fat in the neck. But this is all she needs. She has a nice mid-face, and we corrected the cervical angle, the jaws, the marionette grooves, and the mandibular border. Looking downwards. This is another case, 39, simple max. This is 1 year post-op. You see the change from a square face to a more oval shape. And then we added this third suture. The idea was to have more control over the midface and the nasolabial fold, and to have a better volumetric restoration of the face. As you see in this case, this patient lost 50 kilograms after gastric bypass. She has heavy nasolabial folds, hollow midface that is corrected 1 year post-op, and this is 2 years post-op. You see the stability of the result. Also here, it is not a tightening procedure. It is the volume that is repositioned in the original position. Effect on the nasolabial fold, on the jaws, and on the neck. You see she is wearing her hair upwards. She has no scar here, even in this kind of neck. And this is a 2 year post-op. Another case, with extended max lifting, 2 years post-op, effect on the nasolabial fold, and especially effect on the eyelid. You see the nasolabial groove. The transition from eyelid skin to cheek skin is better, and there is a reduction of the vertical height of the lower eyelid. And this is the direction in blue of this third suture. And this is 1 year post-op, mark the better cervical angle, but also mark the better midface position, the better midface distribution of soft tissues. And this is a little summary. She had platysmal bands. We corrected the jaws, the marionette grooves, downward slanting of the corner of the mouth, the little grooves, nasolabial fold, what we call the barcode on the upper lip, then the better volume in the midface, as you see in detail here, the lower part of the face, and especially the replenishment of the midface, the lower eyelids, simply by this third suture and resection of a little bit of skin from the lower eyelid. You see the better redistribution of volume on the malar area, the correction of the neck, cervical angle, definition of the mandibula, and when looking downwards. And there's a lot of discussion about the scar. These are all scars with the hair backwards. They can wear the hair backwards. I don't see the point. And if you have some spreading of the scar, you can do a scar revision. And if you look in detail, of course, you see always a little fine line with the technique of tangential incision. There is hair regrowth through the scar, and people wearing their hair backwards, they can still wear their hair backwards. I don't see enough of your scar here, and you see the correction of the neck and the midface. Now, why do we avoid opening the neck? Well, it was already mentioned, first of all, there is 3 times more risk of having hematoma if you deglove the whole neck, according to Barry Jones. To our thinking, it counteracts with the lifting of the jaws. You want to lift the jaws and not pull everything to the midline. So it is a little bit unphysiologic because the mandibular, the platysmal edges, they were not at the midline in a younger age. And they cause, in our hands, sometimes some serious morbidity, the so-called gunshot deformity or cobra neck deformity. And after all, we think we have good correction with max lift with vertical suspension of the platysma. And this is a study done by Daniel Labé on cadavers, of course, and he found out, he did all kinds of platysma plasties. He found out that the best correction was vertical suspension of the lateral part of the platysma. And this is a case we operated in the 90s, a deep plane with an anterior platysma raphe, and she came back 2 years later with this kind of deformity. And of course, it's a technical problem. Probably the raphe has loosened, but it's a very difficult problem to correct. And after all, I think we have good corrections with the just vertical suspension without opening the neck, as in this case, and I can show plenty of cases. I think a very difficult case, no definition of the cervical angle. And this case is male to female transsexual with a quite spectacular result in the neck. And this is again the. Now, what are the limits? As Dr. Nahai explained you, it depends on the quality of the skin. This was our first case where you see the vertical pleats are absolutely aesthetically unacceptable. So what can you do? You can do a little intervention, and as you see here, you can do an occipital incision, what we call posterior cervicoplasty, an occipital incision at the hairline, undermine the skin, and re-drape. I will explain this, and this is the final result. So if you end up in your surgery with this kind of folds, of course you will have to do something more. And what you do, you make a zigzag incision at the occipital hairline without undermining the whole flap, undermine this part towards the folds, and then you see here, this is then this is the undermining, redrapement, this is the elliptical resection, and you just suture it without any tension. And I know this scar has a lot of criticism because of bad scar quality, but again, if there is no tension, this will heal well and will give you a good solution. Like in this lady, we did something more. We did a resection, longitudinal resection of the platysmal bands, and a redraping of the skin retroauricular, as you see here. That was planned primarily because you can see it as with the maneuver that Dr. Nahai did. And then you see that we redrape this part, then we resect the bands longitudinally with a little submental incision, and then we can have this kind of result. Still short scar facelift, still we didn't open the whole neck, and we get rid of all the skin excess. This is the 3-quart view, and then gazing downwards. And this is another example. This is a kind of lady that had a scopy narrow, lost 60 kilos, and a kind of lady who enjoyed life. And this is the picture they send you after their surgery. And of course, without makeup, she also, you can see in detail the differences. We did an anterior platysmoplasty, just resection of the bands, and a posterior cervicoplasty with redraping of the skin and correction of the vertical fold. And this is an interesting case. She is 72, has an extended max lift, anterior and posterior cervicoplasty, corner lift. This is 1 year post-op. It looks quite good. It's a terrible neck, but look in profile. This is an overcorrected neck. This is not a neck from a 72-year-old lady. And this is very simple to overcorrect. Probably I took away a little bit too much fat subplatysmal, and I think it's not a good case. It's overcorrected. So I think it's very easy to overcorrect a neck. Second, an overcorrected neck looks very unnatural, and an overcorrected neck is very difficult to correct. So we prefer a natural, slightly undercorrected neck above an unnatural overcorrected neck. How can we push the limits? Of course, you can do more, starting with a short scar facelift, like in this case. He had an upper bleph with an internal brow pexy that works very well in men, an open lipectomy of the neck, and a chin implant. And this is 9 months post-op. I think it's quite a difficult case, very heavy facial features, no neck, and very acceptable. The scar stops here. He has a scar somewhere here through the sideburn, and it stays very insuspectable. And then another case where we did an open neck with platysmoplasty and an open lipectomy, platysmoplasty, and an airlobe reduction is also a little trick to. And this is the 3-quart view and the profile view, still with a short scar ending here, and in the downward-looking gaze. And this is the kind of lady that what we call deflated. She needs something more, and this is the kind of ideal patient that needs extra fat grafting. We put fat in the malar area, in the nasolabial fold, the nasolabial groove, in the marionette grooves, and the perioral resurfacing. This is 13-month post-op in this 67-year-old lady, and in profile view. Now, about the fat, there are some landmarks. In the 70s, we had the implants. In the 80s, we had the endoscopy. In the 90s, the microsurgery. So in the 21st century, it is fat. So the message is, don't miss the fat train. Now, the hot topics about microfat grafting is the reproducibility, the downtime, the survival, and the stem cells. And I will show you some personal experience from me and Alex. This is the problem in the lower eyelid. It looks good after 1 month, but after all the edema is gone, you have visible, palpable nodules. And of course, it's probably a technical problem, but we're not all Sidney Coleman. And these are very difficult problems, and we had different cases with this kind of problem. So the solution was find fat spheres, as the little explained you. There is a relation between the graft particle diameter and the harvesting cannula diameter. So this is the kind of normal cannula, Coleman cannula, 2 millimeter, and this is the micro harvesting cannula. And it's not my idea, it's Trepsat Little Roberts who came with the idea almost at the same time. You see the little holes. This is a cannula. Tulip has this cannula. Welsh has this cannula, and Welsh has, and also Tulip, they make the holes sharp, so the harvesting yield is better. It works like a grater. And nowadays, if you look at this mathematics, what is important is that the radius is inversely proportional to the surface. That means if you have a volume of spheres with half the radius, you have double the contact surface. And what does it mean? That fine fat grafts will have a better survival, so there is less need for overcorrection. So what we do now is we use fine fat for all grafting, and with these grating cannulas, it's very easy to have this fine fat. This is a typical lady who is also deflated, who needs extra volume. She has platysmal bands, jaw, marionette grooves, thin lips, superior iridates, nasolabial fold, an empty midface, and she also wanted a correction of the nose and a correction of a breast hypoplasia. So we worked in 2 groups. We had about 3 hours work. Extended max lift, 3 cc in the lower lip, 5 cc in the upper lip, male area, 2 times 9 cc, nasolabial groove, 2 cc, eyelid cheek junction, lip resurfacing, pinch lower blepharoplasty, rhinoplasty, augmentation mastopexy. And of course, she looked a little bit bruised after 7 days, but that goes away quite quickly. After 3 weeks, she looks like this. And this is 2.5 years post-op, 18 months. Look also to the difference in skin quality, the texture of the skin. There is a lot of discussion about this stem cell thing. This is the clinical result. I can only tell you that her skin looks better, even after 2.5 years, 1.5 years post-op, and 2.5 years post-op. And this is another lady. These kind of eyelid cheek junctions, I don't know a better way to correct this. This is 8 months post-op. This is 18 months post-op. She had fat in here. She had fat in the nasolabial fold, in the marionette group, and a little bit in the upper lip, just a little bit. And so nowadays, fat is added to almost every patient. I think the stability of the result will be more long-lasting because the nasolabial fold, marionette groove, and the eyelid cheek junction, these are the first signs that are relapsing after a while. And with some extra support of microfat, she had microfat in the nasolabial groove, in the marionette groove, and this is 18 months post-op. As you see here, 8 months and 18 months post-op. 8 months, 18 months post-op in profile view. And another case, microfat grafting in the malar area, nasolabial groove, nasolabial and marionette, 8 months post-op. And if you look at her, when she's looking to you, and you compare this picture with the 26-year-old picture, I think we're going in the right direction. Another lady had extra fat with a transparent typoblav, nasolabial groove, marionette, and a rhinoplasty in 14 months post-op. And this is the quality of her scars. And this lady is 53 now, and she was operated when she was 45. She had a simple max lift. And I see her every 2 weeks, and every 2 weeks she asks me, what can we do now? What is the next step? And for 6 years, I said, I will do nothing. But then finally, I did a little homeopathic liposuction of her jaws, put some fat here and here, and this is the result after 7 years. She still looks better than pre-op. This is 6 years post-op. You see the jaws is a little bit coming back, and then we did this microfat grafting. And also for these kind of folds, I don't know a better way to get rid of it. Subcision and place a little bit of fat, like in this case, together with the max lift. These very deep folds. That is the scar. Another case with very heavy, deep nasolabial folds, just by subcision and microfat grafting. Another young patient, simple max short temporal lift, microfat grafting in the upper lip. What she wants, she is young, she especially wants some angularity, some more definition in her face, and that is what she gets with this very simple surgery under local. Patients go home 2 hours after surgery and come back the next day. And then another case, extended max lift, upper and transparent type of lower bleph, nasolabial, microfat, nasolabial fold, nasolabial groove, the lips, the marionette grooves, and then short temporal lift and a periodic resurfacing. This is 1 and 2 years post-op. I think the results are quite natural for a minimal procedure. 3-1 view, 2 years post-op. 1 year, 2 year post-op, and looking downwards. And with the hair backwards, there is no obvious scar. And we go a little bit further with this. We don't use it only for rejuvenation, also for what we call beautification or ugliectomy. And this kind of young lady, she's 17, comes for a rhinoplasty. And if you look carefully, she has a retrusion of the whole midface. So her father was an orthodontics surgeon, and he explained him she needed something more. And he understood it, but he said, my daughter will not have a laparostomy because I know this is a too heavy surgery. So we did the rhinoplasty, and we added 12 cc of fat there, 12 cc of fat there, and in the whole upper lip, from mucosa to skin, we added 12 cc, all fine fat. And this is her, this is her 1 month post-op. The upper lip is still swollen, and I'll let you see the this is 8 months post-op, and you will see it better on the 3-quart view. A flat face has been transferred in an attractive, well-proportioned midface. This is 1 month post-op, of course, and this is 8 month post-op with a normal lip. And on profile view, a 1 month post-op, lip is still swollen, and you have an inversion in the position of the in the anterior projection of the lip with almost perfect profile in the 8 months post-op. What about submandibular gland resection? This is an interesting case. By the way, in men, you see that the sideburn stayed on its place because of the vertical skin regradement. And what you see here is a submandibular gland. I think the more you skeletonize the neck, the more you take out of the neck, the more you pull on the platysmal bands, the more you pull the submandibular gland out of his bed. When you pull on the platysma vertically, you will push the gland back in his bed, and the gland has disappeared in the post-op. Lip lift is a little trick that is nice to combine. This is quite an old lady with no lip, and what we did here, I show you in detail, this is this excision of skin here at the base of the nose. It gives a very inconspicuous scar and a very nice rotation of the vermilion. It's a 5-minute procedure, and it gives fantastic results, especially combined with some lipofilling and with laser resurfacing. What about difficult cases? Just a few cases left. This is, she had a max lift, short temporal lift, an autoplasty, a rhinoplasty, because it's the operating time is shorter. You can combine different surgeries, and I think this is quite a difficult case with very heavy ptotic eyebrows that are corrected in a very natural way. Another case, very heavy facial structures, and this is a very simple surgery, 2.5 hours work with a short temporal lift on profile view. And this is a nice case to end with. This man is 66-year-old. He had a acute myocardial infarction in 2004. He had a stent in his right coronary artery. He was under anticoagulation therapy and was still smoking, and he wanted a facelift. So is he a candidate for short scar facelift? You said no, of course not. His facial features are too, but we did, and we did it in the local, 2 hours 15. 50 minutes work, and this is his result, and I think it's quite acceptable. And I will show you why I'm very happy that we did a short scar facelift, because he had this problem 7 days post-op, little skin necrosis, and it healed by secondary intention with an atrophic scar. But I'm very happy I didn't do it more extensive surgery, because this problem would have been much worse. This is its profile view. You see the little scar here. And this is another case. Max said, does it work, short scar? We think yes. Does it last? We also think yes. This is a 6-year post-op result. And to come back on all the modalities that we have and the choices, the difficulty is what will we combine to have a best result. And some personal considerations from Alex and I think don't obey to the reflex facelift and upper blepharoplasty. Analyze, listen to your patient, personalize your rejuvenation plan, do simple things that work, think in terms of volume, and after all, do volume, think synergistic, combine the right things, do only what is necessary, don't exaggerate, try to have a maximum result with minimal effort. Thank you very much.
I'm just going to give you a little neck talk and focus on two things. One is the corset platysmoplasty, and the other is some subplatysmal maneuvers that I think can be helpful in certain patients in giving a little better result. So the picture on the left is one of my burn patients just prior to a flap resurfacing. It's a very old picture, but it shows the natural anatomy of the platysma, which shows the muscle edges separated and a little decussation under her chin. And the picture on the right is how the muscle looks after a corset platysmoplasty. The two edges have been brought together all the way down most of the neck, so that at least the thyroid cartilage is covered. And it's done with a running suture, creating a smooth, inverted midline seam. So you have a sheet of muscle covering the whole front of the neck. And as the suture, it's usually a 2-layer stitch at least, and it snugs up the muscle and cinches it into the midline. And sometimes, if there's a little muscle redundancy in the submandibular or paramedian area, I'll make a little vertical muscle pleat to tuck away that residual muscle on one or both sides. Sometimes I'll do everything with one suture, the midline, multi-layered midline seam and the paramedian subplatysmal pleating. I call that the go-anywhere suture. And more recently, I've gone back to tucking away any muscle redundancy and tucking up the gland with these 2-way cable sutures that are woven from behind the ear to the paramedian area, make a little pleat and run back, and I'll talk more about that. But those are little variations on the major theme, and the main theme is this midline suturing that I do, which we call the corset platysmoplasty, because it's cinched in the way an old-fashioned torso corset used to cinch in the waist of a woman. Well, why bother doing a corset at all? I mean, we've seen excellent results. Patrick showed some, Bill showed some, and why even bother to do the corset at all? I mean, I don't think you always have to go and open up the front of the neck. There's no question about it. But as far as I think about this thing, I do a corset primarily for one of two reasons. One is because it reduces the chance significantly of recurrent platysma bands. So that's one reason I do it. And the other reason I do it is to allow for the removal of some excess subplatysmal fat, or to do some other subplatysmal maneuvers that we'll talk about, without producing a midline hollow or an overexposure of the thyroid cartilage. Because if I'm going to try to get an optimal result in the neck, and I'm not talking about just shooting for a good result, which is fine. You don't have to open the neck, and a lot of very eminent plastic surgeons are getting away from working in the front of the neck. But in my hands anyway, if I'm shooting for the best possible result that I can get, very often I need to do something up front in the subplatysmal area. And sometimes it's no more than removing just a tiny bit of midline fat. Sometimes it's a little release of some deep fascia or something like that. It doesn't take a lot, but if you're going to try to hone it so it gets as close to perfect as you can make it, then you've got to do some stuff there. And if you do some stuff there, then you've got to put Humpty together again. You've got to put the muscle together smoothly and securely so it doesn't tear apart and leave a midline hollow or muscle edges behind or skeletonizing the thyroid cartilage and that sort of thing. So that's really where the corset comes into play. It's a reconstructive tool that allows you to put everything securely, and then you can redrape your skin flap over that however you like, with or without skin excision, and leave everything nice and smooth and have it stay that way. Well, the first question is, if we're talking about decreasing the incidence of recurrent platysma bands, we need to ask ourselves what causes static platysma bands in the first place. And my way of looking at it is, it could be the skin. The skin is, as we know, let me back up, the skin and the platysma are attached, usually along the medial edge of the platysma by little connective tissue bands, and I call these medial platysma cutaneous filaments. They're not real tough stuff like a ligament, but they're little connective tissue attachments. And here I am, in this patient, I'm lifting up the fat from the platysma with the cautery, so everything's nice and dry. And some of you people, at least in the front row, can see these little white connective bands between the skin, the fat, and the platysma. Goes from the platysma into the skin. These are these little filament bands that connect the two. So as the skin relaxes, as we all get older, it pulls on those medial edges, and you get a skin muscle band. Now sometimes the muscle is also held down by paramedian retaining ligaments off to the side here. It can be in this area over the greater horn or body of the hyoid, or it can be down the edges a little bit more. When they relax, the muscle can relax a little bit too underneath. But from a purely empirical standpoint, I found if you leave a muscle edge behind, sooner or later, the skin's going to grab a hold of that muscle and pull it down into another band. So this case is somewhat illustrative of that. This is a woman who had static muscle bands preoperatively. She didn't want any midline platysma surgery at all. So I simply did a neck lift where I pulled the skin back, pulled the platysma back real tight with 2 horizontal mattress sutures around the ear into the mastoid fascia, and I really locked that in as tight as I could. And initially, her neck was perfectly smooth, the bands went away, it looked great. Then she came back at 3 months and she looked like this. You can begin to see already a little paramedian platysmal muscle band, and here she is at 6 months, and the bands are back. Now that's sooner than very often you see it. But when I was first in practice and I used to pull the platysma back, I used to see very frequently muscle bands come back at a year or two. And I learned that when I started to do the corset, if I put the medial edges of the platysma together so that they were smooth and tight, there was no muscle edge left behind for the skin to grab a hold of and pull down and make another muscle band, just empirically, I rarely saw muscle bands come back. That doesn't mean I never see a muscle band come back. I do, but it's infrequent. I see maybe 1 a year, something like that, and I do a lot of necks. So sometimes you just have to go on empiricism. So that's one of the advantages of the corset. I'm going to run through some of the technical aspects of the corset if I can, because I think it's important. And one of the objections that a lot of people have when they talk about the corset is that if you take these 2 muscle edges and you sew them together, you're going to convert 2 bands into 1 midline ridge. And of course, you can see that sometimes, and I got a few of those when I first started to do that. But the way you avoid that is just learning the technique. And there's some little technical things that you can do so you don't get a midline ridge when you do this. There's no reason to have a midline ridge if it's sutured properly. The other thing about the corset is I never resect any muscle. As thick as the muscle is, as redundant as it may be, I don't take any muscle out. There's no cutting of the muscle. There's no resection of thick edges. There's no transverse cutting of the muscle to get it to drape into the hollow of the neck. The platysma is an elastic membrane, and you can coax it to do absolutely anything you want if you stitch it enough. So if you stitch it, you can make this behave any way you like. And the more muscle you have, the thicker it is, the better it's going to heal together. And I'm rolling these muscle edges together in the midline. So the more muscle I have to heal together and stick together, the more solid and secure in the long run this platysmoplasty is going to be. So I never take out any muscle. But I sometimes have to make a little room along the midline to accept these enrolled edges. So if this is the way the muscle comes naturally here, and I'm looking down at the neck and there's a little excess midline fat underneath the cervical superficial fascia that's bridging from one side to the other, sometimes I have to make a little room in there because I ideally want to have a little concavity to accept the midline edges. So if I'm looking down on the neck and I know I have preoperative bands, or after I've taken away the excess subcutaneous fat, I grab a hold of those edges and they seem a little flaccid, I know I've got to put them together. Or if I know I have to go under and work on the glands or work on some deep stuff, then I know I'm going to have to do a corset after I finish with that. And sometimes it's nothing more than taking out a little strip of midline fat just to make a little room to fold in these edges. Sometimes that's all you have to do, and it's not fancy. And you'll see that everything I do pretty much nowadays, I do with the needle tip electric cautery. This is a bone dry operation. Most of the stuff I do in the neck, there's no bleeding at all. It's all done with the extended microneedle tip cautery on coagulating current. There's no bleeding. You can see exactly what you do. It's nice and neat. If there's a little area of decussation just under the chin and I want to take out a little fat, I just unzip it down the middle with the cautery. And then if the edges are loose and I'm ready to do the corset, I don't have to undermine the edges at all. But if you grab the edges and they're stuck down to the underlying fat and fascia, then you have to undermine the edges for a few centimeters to get them loose enough so that they can slide without tension to the midline so you can do your inverting seam. And again, I very often will just pick that up and cut underneath the edges with the cautery. It doesn't take very long. And remember that the anterior jugular vein lies just underneath the edge in the deep fat, and sometimes I nick it. It's not a big deal. You just grab it or buzz it with the cautery. All right, now I'm ready to start this corset platysmoplasty. And for those who have my book, I've made a few little modifications to how I do the corset now. I used to use for my suture, for many years, a 3/0 PDS suture. And that generally worked very well for me. But what I found is that even though I leave the neck looking what I think is perfect at the end of the operation, and even though the neck may look perfect at a week post-op, every once in a while I'd have a patient come back to see me 3 months post-op, and they'd have a little bulge in the submandibular area, or they'd have a little bit of convexity in the submental area. And I didn't know whether or not it's because the muscle stretched out and didn't hold my stitches. That's something that's hard for me to control. Or maybe the suture just didn't last long enough. PDS hangs around for about 3 months and then it goes away. So I just kind of decided after many years of resisting that I would use a permanent suture to see if that made a difference for me. So within the last 6 or 8 months, I moved to using a permanent stitch. It's a 2/0 Pro Nova stitch made by Ethicon. You probably haven't heard of it. They just came out with it recently. It was made for cardiovascular surgery. It's like Proline. It's the same kind of stuff, but it doesn't fray like Proline. It's stronger. It ties better. I think it's a better stitch. And so that's what I use. But since it's a permanent stitch, I'm worried that the knot, and I tie a lot of knots because I'm running it, could be felt under the skin. So I had to find a way to bury the knots where you wouldn't see them or feel them. So this is a little technical thing that I do now to bury that knot. So when I'm starting the corset, what I do is I turn the left edge over, and I take a bite into the muscle on the undersurface of the muscle just below the chin. And I tie that with just 2 throws, and I leave the short end actually very long because I'm going to tie, when I finish doing the corset, running everything with 1 stitch, I'm going to tie the knot to itself and dunk the knot underneath the edge so the knot is dunked under deeply out of the way. So I tie it with 2 throws, and I leave it long, and I hang a little instrument on it and hang it out of the way. And then I come up through the muscle, and then I take the second bite outside the edge. Always try to get your sutures outside the edge so you're rolling in the muscle edges from the get-go. One of the reasons people get a palpable or visible ridge along the midline seam is because they evert the edges. You got to start to roll those edges in from the very first stitch so you get an inverted midline seam. And then I pull down on the flap edge with my forceps so I kind of align the edges, and I take a bite on one side and a bite on the other, and it's always outside the free edges, and I just start to run this thing down. Now, when you get to a point that's about the level of the thyroid cartilage or just above it, very often you'll see that the edges of the muscle seem to be even more bowstrung than they were to begin with. And that's why for many, many years surgeons would say, well, I can't leave those bowstrung edges in there. I'm going to have to get them to lay into the hollow of the neck. So what do? You take your scissors or your cautery and you make a transverse cut, or you take a medial wedge out of the muscle to get this muscle to lie into the hollow of the neck. But you don't need to do that. The more you suture this muscle, the more you're going to coax it down into the hollow of the neck that you've sculpted for it. So just keep the faith and keep sewing. And it's really when you're coming up with that second layer of sutures that you really snug this muscle into that hollow of the neck. So I run the suture down to usually a point that's about 3 finger breadths above the suprasternal notch. Now, it can be higher up than that. It can be 4 or 5. It can be as low as 1 or 2 above the notch. Wherever it looks like you can stop, where the muscle is tight and snug against the deeper strap muscles of the neck and there's no bowstrunging or anything like that. But usually it's 3 finger breadths above the suprasternal notch. And then I take the same suture and I reverse direction and I start running uphill. Now, if you only use 1 layer and you stop after running 1 layer, there's a very good chance you're going to wind up with a visible or palpable midline ridge because the edges are not perfectly put together. It's still a little irregular and imperfect. You can't do a corset usually with 1 layer of sutures. And you can't do a corset properly with interrupted stitches. You won't put enough stitches in and you'll have some everted edges and it's just not going to be perfect. One of the reasons to run the stitch, not only because it saves a lot of time, but you can just throw in as many stitches as you need to perfect this. This is custom tailoring, and you've got to put in as many stitches as you need to refine this. And it's the refining, a lot of it comes with the second layer. So once you get down as low as you think you need to go, you start coming back. You take little bites down the bottom at first because you don't want to pucker the skin too much. You're going to have to release that skin anyway a little bit later, but you don't want to over pucker the skin. And then you start coming up, and very often you'll see that there's a muscle bulge on one side or the other. And as you get up to it, you take a bite just outside the crest of that muscle bulge, to the far end of the muscle. And then as you go from one side to the other, you just haul in, you cinch in that redundant muscle toward the midline. And then when you get up a ways, you stop every once in a while and you look down and see where you've come from. And very often you'll see some little muscle bulges between some stitches. Well, you don't leave them there. You've got to be a perfectionist with this. So what you do is you just backtrack a stitch or two, take a bite outside the bulge on one side, take a bite outside the bulge on the other side, and just work back and forth and fold in these little muscle imperfections. Then you can head back uphill again. So it's not a straight run up. It's run up, go back, run up, go back. You got to do it that way to perfect it as you get up to toward the chin. Another little muscle bulge we're tucking in. Then when you get up to within a few centimeters of the chin, what I do is I take out the double hook that was holding the chin upward and put it on the lower edge of the incision, and you'll see that there's a muscle bulge on either side of the midline just under the chin that was being concealed by the double hook that was in there. And what you have to do then is imbricate that muscle and tuck it in, otherwise you'll have a little blip and a little irregularity under the chin. So you simply work back and forth from one side to the other and tuck in that muscle redundancy. And then when I get to the chin, I reverse direction and head back downhill for a centimeter or two and tie the suture to itself and dunk it underneath the midline seam where you don't see the knot or feel it. And that's the main component of the corset. But very often when I finish the midline seam and I look underneath the jawline, I'll see a little muscle redundancy there, and you've got to get rid of that little muscle edge. And the way I do it now, instead of doing those interrupted pleats, I've gone to using these woven cable stitches. A couple of years ago, both Fouad and I at the same time kind of gave up suspension sutures because it didn't seem that they worked to hold up glands, and patients complained a little more tightness in the neck, and many years ago I stopped using them. But one of the things as I've been thinking about and being critical of my own results is that when I see these patients come back with a little bulge underneath there, I felt that maybe I was pulling the muscle too much to the midline, and as Patrick said, you can actually lift the submandibular gland out of its nest if you pull too hard to the midline and make a bulge that wasn't there. So I want to try to do something that's going to pull the muscle back a little bit so I equalize the tension on the platysma, so I don't have all the tension forward, and I want to put in a permanent stitch back and forth that may resist this tendency for the gland to bulge out through the muscle. So this is the way I do it now. Again, a 2-0 pronova suture that I tie in the fascia just below the lower ear at the front edge of the sternomastoid muscle. Then I weave it through the platysma for 1 or 2 stitches, and then through the submental incision. That's done from the side. Then through the submental incision, I run it over through the muscle, and I take a bite on the far side and the near side, the far side and the near side, and I make my little vertical muscle pleat with that to tuck away any muscle redundancy and to tuck in the gland, if there's a gland bulge. And then I run the suture back to where I started, just underneath the jawline, and I tie it to itself. And that seems so far to be working a little bit better than the way I did it. It's a little too early to tell. I need to watch this for a couple of years, but I thought I'd show you how I'm doing things nowadays anyway. So that's the way it looks like when I finish most of my corsets now. Just a couple of comments on subplatysmal surgery. I think very often, as I mentioned at the beginning, to get perfect necks, you've got to do a little stuff under the muscle, and it may be just taking out a little midline fat or a lot. You can shave it down a layer at a time, but very often I find after I've done that, I'm right down onto the anterior digastrics. This is a sculptural thing. You know, how much to take out is a matter of just aesthetic judgment, and the more you do it, the better you get at it. Sometimes it's a little midline seam, sometimes it's fat along the midline, and just under the edge of the muscle, you take out whatever you need to do. And once I've taken out what I think is the excess subplatysmal fat, then I look down at the neck and I assess it. And if I've got a perfect hyoid angle, and there's no buzz-strung deep fascia across the suprahyoid angle, I'm finished, I do my corset. But very often, I'll look in there and I'll find that there's a little of this deep investing fascia, I call it the perihyoid fascia, that's a little bow-strung across the angle. And all I have to do is take my cautery and lightly, very lightly transect it, and all of a sudden I've got the perfect angle. If it's real thick fascia, I can lift it up with my forceps and take little pieces, little divots out of it to release that to give me the perfect angle before I do the corset. I call that a perihyoid fascia release. This patient needed a subplatysmal lipectomy and a perihyoid fascia release. So did this guy. To get that good a neck, I had to take out a little subplatysmal fat in addition to superficial fat and do a perihyoid fascia release. Now, once in a while, after I've done the perihyoid fascia release, I'll look in there and I'll see that the anterior digastric muscles are vertically tilted, and they seem to be blunting the angle. It's not hard just to take your cautery and lightly transect the muscles in one place or up a little higher. You're doing this one step at a time. It's a sculptural thing, and sometimes it's just a little release. That's all it takes to give you a nice flat submental zone and a crisp angle. And once a year or twice a year, I meet a patient who's got real bulgy, thick anterior digastrics, and I use my cautery just to shave them down flat. I don't do this very often. I don't think you need to do it, but it should be done in the appropriate patient. That's a guy who had big muscles that we shaved down. And so this patient needed a superficial lipectomy, a subplatysmal lipectomy, a perihyoid fascia release, and a release of his anterior digastrics to give him a good-looking neck. And so did this guy. And I put him in because he's only 1 week post-op to show you that even though you're doing a lot of stuff in the neck, that doesn't necessarily mean that it slows down the healing. You know, you've got to spend some time with hemostasis, that's true. But if you're going for a home run, you've got to do it. There's no way that I can feel a neck and look at a neck and know for sure what I have to do. It's peeling an onion. You get in there, you do one layer at a time, you come to the next tissue plane, you assess what you see what it is, and you decide at the time whether or not you have to modify it or not. Now, the last thing I'm going to say just a couple of words about is the submandibular salivary glands. And I put in this slide because this is the anterior digastrics, and these are the glands. You can see they're in different positions. But this is a condition I call the malpositioned submandibular salivary gland. It's where the gland is held medially in the neck. And when you push on a malpositioned gland, it doesn't slip and slide back underneath the jawline like a lot of glands do. It's stuck anteriorly in the neck. And the reason a malpositioned gland is stuck is because inside the capsule, this gland has adhesions between the capsule and the gland, holding it medially and anteriorly and inferiorly. And it simply won't move. And that's what I call a malpositioned gland. And usually you have to either resect it or mobilize it so that you can tuck it away. Now, if you have a reasonably small gland like this, then I can do a tightening with the platysma over the gland, what I call a buttressing pleat. And then with a small gland, it'll tuck it away, like it did here. And you can make a vertical pleat, never a horizontal pleat that shortens the neck, but a vertical pleat. Nowadays, I use this two-way woven cable stitch that usually includes a little vertical pleat to tuck away the gland. But if I got a real big gland, the only way that I know how predictably to get rid of a real big gland bulge is to do a partial resection of the superficial lobe of the gland. I'm not going to show you how to do that because most of you don't want to know, and most of you shouldn't try to do it because you can get into big trouble very fast. But there is an intermediate operation that you could try to do, particularly if you find you have what you think is a malpositioned gland. And that is, it's very safe, if you pay a little attention to the anatomy, to go inside the capsule, free the gland up, release the intracapsular adhesions, so you've got a mobile gland that then you can tuck away better with the corset platysmoplasty and some buttressing pleats. This is a lady who had a moderate-sized gland that I tucked away after doing an intracapsular release and repositioning. She's got a little bulge left, but it's not too bad. So this is a way that you can kind of take a biggish gland and maybe tuck it away. I open into the gland with the cautery, and once you see inside there's this little filmy stuff, you take a blunt hemostat or scissors and you spread just bluntly all the way around this gland. Everywhere you can find and see, you just spread those adhesions. And remember, the facial vein runs over the top. It's a big blue structure. So look for it. And you get your hemostat between the vein and the gland, and you spread, and you spread, and you spread everywhere. And then you'll find very often that the gland will be attached along the lateral border of the anterior digastric, and those are dense adhesions, and you've got to release it with your cautery. And sometimes you have to release the adhesions just underneath the mandible to get this gland to be freed up. But once it's free, it's mobile. You can move it all around. And then you can take your tonsil tip sucker and push on it, and you'll see that the gland will push up laterally and underneath the jawline. And that's what you got to do to get these glands to move. And then you can put everything together with your corset and keep your fingers crossed because you need some luck, and maybe you can tuck a big gland away. So I'll end there. Thank you.
Good morning, and it's very reassuring to see an audience like this at 7 o'clock in the morning, which shows how much of a visionary Karen Berger is in setting up this session focused on cosmetic medicine. We have an excellent group of speakers, and I think you'll leave today, if not completely changed, you're going to really get a good amount of information. And if you want to start different services in your practice, in your office, I think you're going to get a good, solid base of information and a good idea of what the speakers have done and some of the headaches we have been through in setting up our cosmetic medicine practices. This first presentation is really to summarize what the two American societies, the American Society of Plastic Surgery and the American Society of Aesthetic Surgery, have done or are doing right now in relation to cosmetic medicine, and how we are promoting this among our membership and how we're going to face the competition. And I know there's about 30% of you that are from other countries, and I think you're also facing, I know a lot of South America, but I'm sure Europe, you're also facing a lot of competition among non-core physicians, among non-plastic surgeons in this field. So I'm going to share with you what we're doing in that regard, and then we're going to get into the medical spas and skincare topics. So this was The Economist last year, 2006, that had an excellent article on the $20 billion industry, which is cosmetic medicine. And when you look at the industry, it's an industry that is just starting to grow. It's not going to be a bubble. It's growing 9% per year, and they expect to be a $2.7 billion industry by 2010. The non-surgical procedures account for 82% of all cosmetic procedures. And again, the procedures expected to increase by 9% over the same time. The most rapidly growing areas, you can see, laser and light therapies, Botox, dermal fillers, and no-ablative skin rejuvenation. Medical spas are also a rapidly growing segment. There were in the US 2,500 facilities in 2006, and that's up from 750 facilities in 2004. And in one decade, it has grown to a $1 billion market. And in our literature, you see every day, the ads like this. Most of them from companies or from known plastic surgeons promoting all sorts of magic treatments and lasers. So the competition is quite significant. And in our market here in the United States, it represents up to 60% of the emerging market. And there are 30+ associations involved in cosmetic medicine to this date. Our key competitors, and some of these are now are part of our coalition, the dermatologists, the Academy of Cosmetic Medicine, the gynecologists, internal medicine spas, all sorts of specialists. And we are starting to work through the Injectable Safety Organization. We're working very close to the dermatologists, to the ENTs, and actually to the oculoplastic surgeons in trying to establish a very strong coalition to deal with what we call the non-core physicians. And again, they're also having a lot of meetings in ads like this where an internist is doing a lot of procedures that we feel they're not very trained to do that. This is a data monitor predictions for 2007, that this year the spa facial care would rise 6.7% annually. The body care would increase again at 10%. Cosmeceuticals projected to reach 7.2 billion, and Dr. Graff will share with you. She has a terrific presentation on cosmeceuticals later this morning. And the entire business of medical spas will explode into a $1 billion industry. So why get concerned? After all, we're surgeons and surgery by surgeons. We think that there's a potential to be disrupted by cosmetic medicine. I'll share with you some of the studies, some of the surveys our society did. And I believe we are largely unprepared to address this threat. And as surgeons, we think as no-invasive treatment is sort of trivial. And how do we plastic surgeons view ourselves in cosmetic medicine? Do we want to be a slice of the pie chart, or do we want to be the core? Why be the core? Why should we be the core? We certainly have the data to substantiate safe outcomes. We have the professionalism, the training, and the ability for the patients that are seeking cosmetic treatments. And we have an opportunity at this time to own cosmetic medicine. Core strategies, we believe that plastic surgeons are the best trained to provide comprehensive cosmetic care and to address other issues of wellness-based care. The bottom line in this business, if you snooze, you lose. And we're certainly not going to affect most of the mature, well-established plastic surgeons. But young plastic surgeons will need to offer cosmetic medicine to survive. So it's really an issue with our specialty. So what are the societies doing? The first thing was established back in January 2007 was the Cosmetic Medicine Task Force. And that was through the Cosmetic Surgery Alliance, where the Aesthetic Society and the American Society of Plastic Surgeons got together through their leadership and set up this task force to deal with this. We also set up medical spa workshops. There's an injectable safety program through the Aesthetic Society, and I encourage you to look at their website. The Cosmetic Medicine Task Force was set up with equal amount of individuals from both societies. And I'm going to give you a very brief update what we have done since January and share with you the results of our survey. And if that's not going to wake you up, then I don't think what else we can do. We have done 3 kinds of research through public survey, and member interviews. The public survey involved over 1,000 women, the member survey 260 members, and then member interviews. We got 40 members, members of both societies, and through long phone interviews, really discussed with them issues related to cosmetic medicine. In the women interview, in the patient interview, are past and potential cosmetic patients distributed throughout the country. And I'm just going to share with you some basic, very interesting slides, very interesting findings. For example, plastic surgeons likely lead on invasives because of far greater concern about possible complications. When you look at the 2 lines, the blue line are invasive procedures like facelifts, breast procedures, tummy tucks. So of the 1,000 patient survey, most of them, 80% of them would answer that they would have surgical procedures done by plastic surgeons. Injectables is right at the middle, between 50 and 60%. And the black line at the bottom are non-plastic surgeons, all the other specialties. And you can see that injectables, vein treatments, skin peels, all sorts of non-invasive procedures, the majority are being patients are preferring non-plastic surgeons. And when we asked them if you had to choose one, just one, which provider would you choose to perform a surgical procedures? 93% selected a plastic surgeon. if you had to choose just one, which provider would you choose to perform an injectable procedure? 40% answer plastic surgeon, almost 40% answer dermatologist, but 21% answer a non-plastic surgeon, non-dermatologist, and that includes gynecologists, dentists, oral surgeons, internists, etc. So it's clear that for minimally invasive procedures, plastic surgeons are not the providers of choice. Now, this is probably the most important slide, the 747 effect. When we ask them, after a positive non-invasive experience with a non-plastic surgeon, 53% responded, 47% had a non-plastic surgeon doing their procedures, doing their fillers or injectables, and only 7% here for surgery. Patients that had successful non-surgical procedures with a non-plastic surgeon, when they came back when they decided to have their surgical procedure, they stay. 47% of them stay with the non-plastic surgeon for their surgical procedure. So that was a rude awakening to the reality. So our key findings on the public survey is that patients perceive the risk of injectables to be higher than the risk of other non-invasive procedures. For most minimally invasive procedures, plastic surgeons are not the patient's first choice anymore. Patients value unique skills of plastic surgeons for the invasive procedures. Cost is also a factor in non-invasive procedures. And this is really the key. After a successful non-invasive procedure by a non-plastic surgeon, patients are just as likely to choose this provider for their surgical procedure. So if you're not getting them early in doing their fillers and Botox, 47% of these patients, almost half of them, will stay with non-plastic surgeons for their surgery. The member survey, as expected, over 90% of us are doing Botox, wrinkle fillers, skin peels, and non-medical skincare, about 66%. And another interesting finding was that the number of years in practice does not determine how likely you offer non-invasive procedures. You can see minus 14 years in practice or over 15 years in practice. We're pretty much offering, the group that is offering non-invasive procedures is pretty much equal. So age is not a factor. And was very reassuring to see that many plastic surgeons, including in the survey, are still performing many of the moderately invasive procedures. This is a busy slide, but in essence, it shows that most of us that were surveyed believe that we're still going to continue to grow. The non-invasive practices will still continue to grow between 10 to 25% next year. This is our members answering. The common challenges in a cosmetic medicine practice or non-invasive practice are inventory management, equipment decisions, recruiting, retaining, and training staff, maintaining professional satisfaction, competition, profitability of less invasive procedures, and patient education. This is where we got these challenges, we got these answers through the phone surveys with 40 of our members. So the key findings in our member survey, that members of all ages have embraced cosmetic medicine procedures. The majority of the members survey expect a high growth for non-surgical procedures, between 10 to 25% a year. Members perceive all non-surgical work to be lower margin work, including injectables. There are consistent challenges that most members face as they expand into cosmetic medicine. In this group, the task force, after many conference calls and meetings, made some recommendations to the two societies. And the recommendations included adopt a 4-level platform to cosmetic medical care, and basically we divided what we do, what at least the member survey do, in four levels: one invasive, one moderately invasive, minimally invasive, and non-invasive procedure like spa treatments. We also recommended to have an aggressive approach to the injectable market. We wanted to differentiate our message from the industry message by creating new materials that promote this 4-level platform and the unique benefits of choosing a plastic surgeon. And we also want to develop member resources to better position our members for success in cosmetic medicine. And certainly a public education campaign, and that would attract the media for this purpose. And the goal was to educate the patients on the unique expertise plastic surgeons bring to cosmetic medicine, and also to optimize the incorporation of cosmetic medicine in your practice or your medical spa. So in summary, these are the things we're doing for the past 10 months. So that's what I want to share with you on the cosmetic medicine work that's been done through both of your societies. If you need any more information, you can contact the task force members or both societies. This first panel, we're going to then focus a little more on how to set up your skincare center. We're going to get into a little more practical aspects of how to incorporate these treatments in your office. Many of you are already doing that. Many of us are doing some different levels of cosmetic medicine. Some of us are doing our own Botox and fillers. Some of us hire a nurse to do it. So you'll find that you can have this in one little room in your office, or you can set up a whole medical spa. And we're going to approach this in many different ways. I have two outstanding speakers this morning. Dr. Raft from New York, who is a very world-renowned dermatologist, has a lot of experience in skincare and cosmeceuticals, and has a very busy practice. And Jason Posner from Boca Raton, plastic surgeon, who has done a lot of work in business planning and organizing medical spas. So I also going to tell you my experience. So you get a variety of different information, a variety of different approaches to cosmetic medicine, plastic surgery, or in a physician's office. So let's start with you, Jason.
I want you to take off your medicine hats today, and let's be business guys and see what we can do. Disclosure, I'm on the clinical advisory board of Bioform. I'm not going to be talking about fillers today, and I am a consultant for Cyton, and I will be speaking about lasers later on in the day. These are statistics that we've all seen. This is from the American Society for Aesthetic Plastic Surgery. But I want you to look at these statistics in a different manner. I want you to look at them and critically analyze some of the data here now. Okay. First thing is, let's look at 1997 and let's look at 2006. First of all, the number one procedure that we do now as surgeons, as surgical procedures, is liposuction, and that's number 7 on our list. Okay. So first of all, as surgeons, we operate less than we think we operate. We actually do a lot more fillers and Botox and lasers and other things than actually surgery. Number 2 is, look at 1997 and look at all those non-applicables. Look at the data in 2006. Okay. Many of the procedures that we're doing today, we weren't doing in 1997. We barely even thought about them then. So it begs the question, what's the practice of plastic surgery going to be like in 2016, 2026, 2036? Okay? I'm going to be saying this a few times today. You need to create your infrastructure for the future, because things are changing and you can either be a part of the future or you can be stuck in the past. Look, Botox, 3 million procedures in 2006, and you're going to see some further Botox data in a few seconds. Quick facts from ASAP 2006. Non-surgical procedures were 83% of what we did compared to 17% surgical procedures. Surgical procedures down 9%, non-surgical procedures up, and it's a $12 billion industry. Demographics are pretty interesting. Mostly women, some men, minorities 22%, definitely an up-and-coming emerging market. But I really thought when I looked at this data that the patients would be older, but the bulk of the patients coming in are 35 to 50. That was interesting to me when I analyzed the data. I put this slide in yesterday. I read this book, and it's on the bottom. It's called Boom, Marketing to the Ultimate Power Consumer, the baby boomer women. So baby boomers were born between 1946 and 1964. There are almost 80 million baby boomers. First group turned 61 in 2007. They're healthier than their parents. Right? Life expectancy is longer than their parents. They act younger than they are. In this book, they said that the average baby boomer woman thought she was 10 years younger than her actual age was. Okay? The bottom line, if the economy stays okay, the next 20 years are going to be very busy for plastic surgeons, and that's a good thing. Projections. This is from Michael Moretti from his Aesthetic Buyer's Guide and from MIInews.com. If you don't get his journal, it's Aesthetic Buyer's Guide. It's pretty interesting. You have to really look at it critically just to kind of see what are the new procedures that are coming out. But light-based treatments, this is worldwide projections. 2006, $9.1 billion industry. 2011, $17.4 billion industry. Botox is going to go up from $3 billion to $6.6 billion, and the dermal filler market is going to approach $3.5 billion in 2011. So this is definitely a good market that we're all in. There's been a strong shift towards non-invasive procedures. This is quite clear in the literature, quite clear in all the data that's been accrued. The aesthetic market is a lot larger in the non-invasive market than it is in the invasive market. I can't tell you how many patients are afraid of surgery, are we all more willing to come in for a Botox injection or any other filler. But I'm a surgeon. I want to be in the OR. That's okay. We can hire staff while you're in the OR. And everyone comes up to me all the time and says, well, you do all these lasers. I don't do all these lasers. I'm in surgery 3 days a week. I'll do the deep resurfacings, but my staff do all the other lasers. I direct them when I see all the patients, but I'm in surgery because I'm a surgeon. Okay? This was the practice of plastic surgery 25 years ago. You had a knife and a fork, and you cut, and you discharge it from the practice. That's not the state of plastic surgery today. This is the state of plastic surgery today. I do vaser, I do endoscopic surgery, I do lasers, I do Botox, and I do fillers. And Ronaldo and I were speaking last night at dinner, and we said, well, the people on these podiums, they talk about one thing. Sid was talking about fat, and Joel was talking about necks, and they are the experts in those fields, and people will fly from all over the world to see them for those particular procedures. But most of you in the audience, and Ronaldo and I, that's not our practices. We have multidisciplinary practices. I might have a breast, I have a face, I have a nose, I have a laser. We do a lot of different things. So that's the current nature of a general plastic surgery aesthetic practice in this day and age. Now, this is what's coming. Okay? This is available to our colleagues in Europe right now, and this is just one of the things that's coming. This is UltraShape. This is a non-surgical body contouring device. It blows up fat like lithotripsy. Okay? I was interested in this procedure. I went to London. I was giving a talk in London in July, and I had this done because I wanted to see what it was like. It was very interesting. I had this procedure. It took 45 minutes, and I walked to my hotel about an hour away. I was a little swollen, and I saw a little fat reduction. Okay? It's an up-and-coming procedure, and this is something that when it comes, you have to be aware of it because patients are going to ask about it. Is everybody a candidate for it because it removes about 500 cc's of fat per treatment? Probably not. But I can guarantee you that you will get many calls in your practice about this device when it comes out and when it becomes available. And I suppose that my liposuction practice will probably double when I get this device. This is a market research. This is from Robert Grant. He's the president of Allergan, and this was published in the Aesthetic Buyer's Guide in July and August of 2007. 27 million women, U.S. women, could afford Botox and are aesthetically minded, but only about 1 million of them are getting Botox on a regular basis. This is 3% of the addressable market. Okay? There is tremendous room to grow with these things. Okay? My business plan is quite simple. I tell this to the patients. I'll tell this to all of you. Keep patients in my practice. Renato just showed you overwhelming evidence of why you should be doing this. Because if you don't keep them in your practice, they will end up having liposuction by the podiatrist down the street. Okay? No question about this. Patient retention is key to this. There were 2 studies. One was an Allergan Canada study. One was a Tina Ulster study. They showed that patient retention in their Botox patients was between 55 and 57%. That is terrible. Okay? That means we're losing 40% of our patients. 40% of the patients that came to your office are going elsewhere for other procedures. That is bad business. Okay? It costs between $150 to $1,000 to bring a new patient into your practice. Advertising, word of mouth, all that things. Okay? This is data from a book called Customers for Life. How to turn that one-time buyer into a lifetime customer. It's about a car dealership in Texas. They said that the average Cadillac purchaser who walks into their dealership and buys a car is worth $517,000 to that practice, to that dealership. Okay? Let's kind of turn that around. Let's look at your patient's value in terms of Botox. Okay? Let's look at the business of this. Let's say you do 2 Botox treatments. A Botox treatment, let's say you charge $600 and your cost is $200. Let's say you did 40 units. You do this 3 times a year. At 5 years, that's a profit in your pocket of $6,000 if you kept that patient coming back to you 3 times a year. Okay? Let's add a filler to that treatment. Let's say you charge $650 for a syringe of Restylane and your direct cost is, let's say, $250. You do that twice a year. Okay? That's a profit of $4,000 over 5 years. With Botox, that's a profit of $10,000 in your pocket over 5 years if you kept that patient in your practice. Okay? Add plastic surgery, add lasers, add spa service, et cetera, et cetera, et cetera. That's a lot of money per patient in your practice. So it costs a lot to lose patients. That's quite obvious. A lot of patients start with little things. So when they come to your practice for skincare, don't blow them off. Give them the same attention that you would that facelift patient. Because down the road, they will turn into surgery patients. The data is quite clear that they will stay with you. If they stay with you, they will have a surgical procedure with you. Renato just showed that data. Okay? I don't get referrals from other doctors. Those days are gone. Okay? I get referrals from patient referrals. And customer service is absolutely critical. About 25% of my practice is non-surgical in terms of money coming in. But again, I only do a little portion of it. And these are 2006 data. In 2007, my use of Botox and fillers has decreased while my PA and nurse practitioners' use has remarkably increased. Opening a non-surgical center, this is what we're doing now. It takes a lot of effort to open one of these. Renato can attest to that. We're in process. We've been building now for a year. We're opening the first of the year. My walls are going up. My floors are going up now. I'm going to talk for a few minutes about what we're doing and my vision for the future. Okay? The first thing is, this is business. If you want to open up a Medi-Spa, take your emotion out of it. Okay? You have to plan appropriately. Plan your work, then work your plan. What about a spa consultant? I hired a consultant. No, we're in surgery all day long. How can you possibly plan a new business and meet with banks and architects and things like that if you're seeing patients in surgery full time? It's impossible. Okay? What do I know about business? Okay? I've made my mistakes. That's how I learned about business. But I hired someone who knows about this and built a lot of Medi-Spas. First decision, financially, alone or partners. Okay? I have a partner in my practice, he's a dermatologist. I'll start with that in a few minutes. Site selection, on-site or new location. Mine's on-site right now. I was doing a lot of this in my practice. I have currently 5,000 square feet. We just bought 6,000 square feet, so we'll have 11,000 square feet for our combined centers. They're next door to each other. If I had to do it again, I'd start with a fresh building because I like that concept a little better. It's a little bit easier, but it's location matrix is interesting. My business consultant did a 10-mile radius looking at all the other practices and called them all up and actually gave me in my business plan an analysis of everybody else within 10 to 15 miles of us. What lasers they had, what did they offer. Do you lease or you buy your building? My building went condo, so I bought it. Freestanding or not, I would do freestanding if I had to, but I'm not. I'm in an office building. And build alone versus renovate, you really have to look at this individually and how it best works in your city and what works for codes and things like that. You need a business plan, and a business plan is not so easy. You have to look at startup costs. You have to look at build-out costs. You need working capital. You need advertising. Menu of services, unit sales, competitor analysis. I mean, it's quite an undertaking to do this, but if you're going to do it, you're going to do it right. And this is some of the things in our business plan, from a summary to a compensation to physicians to PAs to plan for growth and what happens if things go bad and you need some money in the bank before you get started. So it's pretty comprehensive. And financing, well, we went to the bank. We took our business plan to the bank and we got money, but there's other ways to get money. If you have a lot of money, family money, you do it yourself. You can ask your uncle for it. You can get private investors and medical-based loan companies. But most of us will take our business to the bank. In construction, you have to buy equipment, you have to market. We're in the process of building 2 new websites. You have a grand opening. We're having a huge grand opening party. You need working capital. We're sending our staff for training. So it is a long haul and it costs a lot of money to get started. This is what we called our center, Sanctuary Medical Aesthetic Center. We wanted to get away from MediSpa. And the question is, well, why am I doing this? Well, I'm stuck. I have no more room to grow. I'm at 5,000 square feet, and we're on top of each other in 5,000 square feet. It's profitable. I'm not doing this for my health. I'm doing this to make some money. And this is the future. And I'm setting up the infrastructure for the future. Because all the data that we've seen and heard shows that the future is going to be non-surgical cosmetic things. That's what's coming. That's what the people want, and we're going to be doing more of it in the future. I hired a consultant for my spots. It's now Sanctuary Medical Aesthetic Center. I self-finance the architect. I self-finance the demolition. I self-finance a lot of attorneys. And there's a lot of Stark law regulations with this. Hiring people on percentages and things like that, it's very difficult. I'm putting together dermatologists, plastic surgeons. I have an anti-aging physician. My father's involved with me as an internist doing weight loss. What do you do with your existing lasers? How do you bring them into the practice? They've already been depreciated. So there's a lot of business aspects to this that need to be addressed. So we have 6,000 square feet. That's next to my existing office. It's a condo. It's going to open in January 2008. There's two principals, myself and David Goldberg. He's a world-renowned dermatologist. He's off-site. He comes down a couple of times a month. We set up as a separate corporation for liability and estate planning. One company owns the property, a second company owns the business. I'm currently selling him half of the property because he wants to be sold half the property. It's better to do this from the beginning because once you start to change things around, the banks have a really hard time with changing things, and there's a lot of penalties involved in changing these type of things. So we ended up with 100% financing. I got back all of my existing money that I put in because my existing equipment was viewed as my contribution. You have me involved. I have a retired plastic surgeon named Kurt Wagner from Beverly Hills who retired to Florida, and he comes in every day and helps me. I have another part-time plastic surgeon, Christine Haugen, a dermatologist. I have an anti-aging physician. He will be full-time. He's now there half-time now. He's there 2 days a week. I have a bariatric physician. My dad comes in. He doesn't pay me rent, and I don't take any of his money. It's sort of payback for medical school. And he does weight loss, and that really works with our patients. Every patient who comes in for liposuction, if they're heavy, they see him. They see our nutritionist. So we offer comprehensive care. Every woman who comes in who's 55 years old or 60 years old who has poor skin and who's hormonally depleted, we'll talk to them about our anti-aging clinic about hormone replacement. And we're hiring and adjusting as needed. I have a vascular surgeon also who comes in once in a while to do endovenous procedures. I have one PA right now, a laser tech, an esthetician, a nutritionist, a medical assistant, and this is just for the spa. This is not my practice. This is just a separate spa personnel. Office manager, a couple of front desk people. And our plan is to hire more people when these people hit 80% of their projected time frame. And this is what we do in our spa. We do Botox. I have 9 types of fillers there. We have lasers. We have hair removal. We do fractional things. We do vascular lasers. We do tattoos, skin tightening, cellulite, laser liposuction. That's mostly in my office now. And post liposuction. Renato got me involved in this. He said, okay, after every liposuction, they need to do lymphatic drainage. So that's what we're starting now. We hired a massage therapist for that. Our anti-aging physician does well patient care and hormone replacement and sex enhancement for men, antioxidants and vitamins, weight loss. Weight loss physician, he creates a lot of flow. He sees about 80 patients a week through the practice. I can tell you that once they're in the practice, some of them get Botox and fillers and liposuction and facelifts. And nutritionist is just part of the comprehensive care. We try to put it all together, and that's my vision for aesthetic care in the future. And what's coming? Well, these non-invasive fat removals are coming, and better skin tightening procedures. Right now, we have 4 skin tightening lasers. Do they work? A little bit. Okay? But what about after facelift? We try to get every patient after facelift, after liposuction, after whatever, to come into the spa now and do skin tightening procedures. Now, think of your market share for this. Every woman after childbirth, they have extra fat. Every woman after they deliver should come in for ultra shape or liposonics and some skin tightening. It's a great market share. And less invasive skin rejuvenation. We do a lot of fractional lasers now. I mean, it's unbelievable how many patients who've come in through our practice in the last few months for these minimally invasive things. Do they need maximally invasive things? Yes. Are they happy with their minimally invasive things and no downtime? Yes. So we're making patients happy and they're improving. They're not at the level that I would like to see with my full face resurfacing and all the rid is gone, but they're happy and that's what counts. Because we're in the business of creating happy patients. And that's it for today.
What I thought I should, what I'd like to share with you is really my personal experience in doing this and apply some of the practical things we do. Jason summarized very well the business plan, and again, we have a limited time, so feel free to contact us, and I call Jason a lot and try to figure out how to do things. I want to share with you my experience and make it very practical because we are surgeons. I mean, we're both board certified general surgery and plastic surgery. I mean, we're surgeons like you. We're not pretending we're not surgeons. I think we're just focusing a little more in a more diversified practice, including cosmetic medicine, than many of our colleagues are at this point. And the way I see this whole thing is to benefit the patient. And it was not until 3 or almost 4 years down with a medical spa that I started seeing some profit. So I really think if you're going to do this, either in your office, in a little room, or in a big, grandiose project like Jason, the ultimate benefit is for your patient. I summarize my experience in what I call the complete aesthetic package, and that's what I'm going to focus my presentation today. So just for understanding the role of medical spas in aesthetic surgery, I'm going to divide this in time to change, changing times, services, how you set up your team, the package, which really includes the plastic surgery part of it, and some legal issues. I don't want you to think this is not without possible legal implications. So time to change, I hope the survey I showed you and what Dr. Posner just shared with you was enough to wake you up for this issue. And again, why should we be concerned? But also keep in mind that it's not the strongest of the species to survive, not the most intelligent, but the one who is most responsive to change. And I think our specialty is facing this challenge right now. And we face many challenges as surgeons, and especially in plastic surgery. And this is our challenge right now. But also things change. Even our techniques change. We're doing straight incisions for abdominoplasty in the 60s and 70s, and then we went with the French cut, and now it's coming down again. I actually ask my patients now because I'm at loss, and they'll tell me no, I'm wearing a little lower, and I ask my wife, and where the incision should be. So changes also happen in the fashion. And most importantly, the patients have changed. Today's patients, they want quick, safe, ethical, and effective solutions. They want results, and they want results right away, and they want results to last. They want to be pampered. They want to be taken care of. And they know what's going on, and they want to know what's next. And many of these patients that come to our office today are not prepared to have surgery yet. Again, if she would come to my clinic today, she would get the whole thing, because the skin has to look better, surgical procedures, skincare procedures, it's not just surgery anymore. So in 2002, after I left my 13-year of full academic practice, my mission statement changed. And the idea was to combine pre- and post-surgical care to plastic and reconstructive surgery patients and combine them to a conventional medical spa treatments under direct supervision of a board-certified plastic surgeon. I'm not easygoing as Jason is. I'm a very control freak. I cannot put together this wonderful team that Jason did. It had to be under my supervision and only my supervision. Also, after 13 years in a university setting, you can tell why I want to go big time and have a real nice place for my patients and for my staff and for myself. And for lack of a better name, we call it a medical spa. And I agree with Jason, that term is probably overused, and and I appreciate what you share with us. It's more of a multidisciplinary approach to what we do. And really, the goal was to take somebody in their mid-50s, and be able at 3-4 days have them in the office feeling good, looking reasonably well, and provide them service that will stay there and keep those patients in the office forever. So that's what I'm going to present to you, things that we can do that will help and enhance the surgical procedures that we love. Services. Jason mentioned a little bit about services, and you look at these logos, this is good service. Patients, they want to see and feel service quality. It's not so much the product anymore, it's the service that you offer. And unfortunately, most patients lack that knowledge that is needed to judge technical quality, but they will answer to service when they see and feel one. The team is extremely important. This is not just going in, doing a facelift and sending the patient back home. This involves a lot of people. And the right staff is critical for the success of your surgical and medical spa practice. And forget the visionary. It's your staff that's going to make it or break it in your practice. Keep in mind, employees are physician extenders. Hire employees that make you look good. It's very important that they deliver the same message as you do. And again, develop a team focused on the business of patient satisfaction and safety. Don't gamble on your future. Choose intelligent, flexible patient advocates. Pay them well. Delegate tasks and cross-train employees. Have staff focus on revenue enhancement. Do what Jason suggested. Get them to read the same books you're reading in business. Go back to your office on Monday and talk to them about the numbers I showed you, that those patients, if we're not retaining those patients, they're going to go someplace else. And most importantly, be a patient advocate. Have a team effort that communicates patient satisfaction, patient safety is our business. This is going to be the core of my presentation when we're going to talk about complete aesthetic package. And I'm going to give a few tips that you can take right to your practice and do it tomorrow. So how do I do this? Basically, is what you're doing now, and maybe just putting it together so that the whole staff understands the concept of complete aesthetic package. It involves a plastic surgery consultation that I do with my nurse and my certified medical esthetician. We adopted this for facial rejuvenation and body contouring. I'm going to focus today mostly on faces. It involves a skin evaluation and skin preparation, which is free and part of that facial rejuvenation consultation. If it's a body contouring procedure, then she's going to be, or he's going to be recommended to a nutritionist and personal trainers. We don't have them in our staff, but we have people that we like. Lymphatic drainage massage, mandatory post-operative for all cases, reconstructive or aesthetics, camouflage makeup, micropigmentation, and all the ancillary procedures. So if we divide this in preoperative, intraoperative, and postoperative, how do we make this thing work? Preoperative, all these patients that come for facial rejuvenation, they're going to go to pre- and postoperative skincare, pre- and postoperative IPL, Botox, Thermage, or even hair removal. It's all part of the package. So no patient will come in today and have a facelift tomorrow. They'll have 2 to 3 weeks of an aggressive skincare program. And that's why I have the esthetician involved with me from day one. They walk in, they're going to meet one of our medical estheticians, and she'll take it from there. Many of these patients immediately will get involved with Botox. And let me just give a few tips on Botox that you can take to your practice tomorrow. Buy those little insulin syringes at Walgreens. They're a lot cheaper, and they have a smaller needle, and they're not as painful. And adopt the Botox chart. It's free to you from Botox Cosmetics. I use this chart a lot to educate the patients. I show them what I'm doing and help to guide me and guide my nurse in the units injected in any site. Remind your patients to come back. Many patients don't remember they are busy. I learned this with the dentist. The minute they're paying their injection today, a card with a stamp goes into a box, and in 3 months that card is going to go into the mail. And patients love that. They thank us all the time. Thank you for reminding me. And offer discounts. So use these things to help the flow and help your practice. Fillers, and Dr. Graff is going to expand on this, but let me just give you some pearls on fillers. I adopted topical anesthetic. I used the one of DMSO, much better than Emla, much better than anything else I have used. It's quick, so you don't need to let them sit for 20, 30 minutes. Was done at University Pharmacy in Salt Lake. Just email to me, and I'll send you the prescription. So fillers for the nasolabial folds, that's all I do. I do creams. Fillers for the lips. I use, after trying many numbing creams for the gum, and many dentists I talk to, we end up buying Topicali. Comes in different flavors. It's cheap, but effective. So my nurse applies that. I can, about 5 minutes, I come in and I do blocks with Septocaine. I do infraorbital and mental blocks in every single lip augmentation I do. I used to see patients crying. I just don't like that. So very easy to do. It takes about one of those vials. It's easy to apply. And then ice. Ice is key. We tried all different kinds of ice packages. This is the cheapest way to do it. And just have the patient applying in one room, and then you're in another room seeing a consultation. So very quick, very effective, safe, and painless. A few tips on laser hair removal. This is done by estheticians in my office, but they have developed over the years better ways to do it. So you can take to your office if you're doing this. You use the cream, use the ice, and slide this as you go. And by cooling just before you fire the laser, it helps a lot. IPL has been a great. Probably the best machine I have in my office. Again, a certified medical esthetician. In Utah, a certified medical esthetician can run this under my supervision. You have to check your state regulations to see if you can do this. But it offers this kind of improvement. This is all after pregnancy, and you can't get this any other way. Patients love these treatments. But also, it helps me with the surgical procedures. This is a 62-year-old marathon runner in Utah who came in, had a facelift, and then years later came in and had IPL treatment. And you can see, look at the quality of the skin. I mean, here you get a facelift, you get some improvement, but then you treat the skin, and you get a fantastic improvement in skincare. Again, another example, patients for facial rejuvenation. I'm going to show you surgical cases where the preoperative treatment, aggressive skincare treatment, and IPL and skincare, it really enhances the results of your surgery. And I think you cannot, in this day and age, you cannot deny this type of treatment to your patients. Again, you can lift all these tissues, but unless you clean up that skin, you're not going to get a total patient satisfaction. Thermage. I see all these Thermage patients. We still get a very good satisfaction, 2/3 of our patients, but I'm the one that see them. I see them as a free consultation, and I tell them right there, you need a facelift. You can have Thermage. And I think the patients that do not want a facelift, patients that do not want surgery, I found it to be a good improvement when you combine it with other therapies. So it has a place in my practice. I haven't had any, I had patients that I didn't see a great improvement. I stopped comparing to facelifts, and you talk to your patients, they are happy with the results. So we look at all these preoperative treatments, some great, some okay. Intraoperative, that's what we do best. We are surgeons. So what can you do intraoperative to minimize morbidity, to minimize recovery time, to improve bruising, swelling, and get a better recovery? Endoscopy certainly is one of those things. I really like minimally invasive surgery. I've been doing since '94, and has really helped to improve my results. I mean, this is a 13-year-old endoscopic brow lift, pure endoscopic brow lift. It has helped me a lot to improve, to provide forehead or periocular rejuvenation in male patients. It has helped to improve brow asymmetry, and you can see the preoperative view in 5 years post-operative view, the split face, and you can see it's very clear that endoscopic procedures can provide the same result as the open approach. The fixation in my practice today, it went from tissue glues to sutures to percutaneous screws to absorbable screws. And for the past 5-6 years, I've been using the Endotyne. I like it because it's buried, the patients don't complain, and it dissolves with time. Mid-face aging, I've been working mid-face for the past 7 years. Our first paper came out in the year 2000, and it's something that we're seeing a lot in our practices. And you all are familiar with the pathology of the anatomy pathology of the mid-face aging. And these are patients in their 40s and 50s. Some of these patients are not ready for a facelift, but they will tolerate a minimally invasive approach for mid-face rejuvenation. And again, just to review what was talked about yesterday, you see the descent of the lid-cheek junction, increasing prominence of the nasolabial fold, loss of in-cheek projection, and descent of the malar fat pad. So. And that's pretty much our patients today coming in with mid-face aging. We have to offer something better than the traditional open approach. There are many published techniques. You saw some of the masters yesterday talking about the lower eyelid approach, the open temporal approach. I've tried them all. I think they're all excellent. I like to do it through the endoscopic temporal approach only. I think it's, again, minimally invasive. It's a procedure that takes, in my hands, less than 45-50 minutes. Patients do well. And again, some of these patients are not ready for a facelift, and I don't plan to, with a mid-face, to give the same results of a facelift. The same company that came out with the Endotyne came out with this longer Endotyne, and it's very easily inserted after a temporal dissection, endoscopic temporal dissection. You apply this device, elevate the mid-face, suture the sheath after compressing the tissues into the tines. And then you suspend it with the patient in a sitting up position, and you suture in the deep temporal fascia. Again, it's a very safe dissection. I haven't used the intraoral incision for several years now, and it has really cut down a lot of the operative time. These are your typical late 30s, early 40 patients that come in for some mid-face enhancement, and excellent candidates for this kind of a procedure where you see the mid-face improvement with a temporal incision only. Again, these are patients that, of course, would benefit from a surgical, more invasive facelift. I do SMAS all the time. I do next, but I'm very happy with the results of a mid-face lift through an endoscopic approach in the temporal area. Actually, this patient was done 2 years ago, and you can see the improvement through an endoscopic brow in the mid-face, and she has just scheduled her lower facelift for 2008. Why, very briefly, why endoscopic techniques are still used in my aesthetic practice? I find them very reproducible with good long-term results. There's an increased patient-surgeon satisfaction with smaller scars, less bruising, and faster recovery. The endoscopic magnification provides a much better anatomical visualization, less morbidity, and in my opinion, is an integral part of modern, less invasive facial rejuvenation surgery. It goes with the whole package. Fibrin glue, very briefly, improve hemostasis, will not prevent a hematoma, but improving hemostasis. It has been documented to decrease postoperative swelling, decrease bruising, no drains or dressings in most patients, and improve patient comfort. I tried in the endobrow lift. I wasn't happy with the results, but I do use it in all my facelifts, in neck dissections, in my mid-face, endoscopic mid-face. I would encourage you to try if you haven't done it, and if you do it, use the spray system after you complete your SMAS. So in your neck dissection, just before you close, spray down in the neck, spray over the SMAS, and be sure you apply 3 to 5 minutes pressure. And I do that after I trim my preauricular scar, so when the nurse is applying pressure, I'll go and work and close the preauricular scar, so it really doesn't add any time to the procedure. I don't have any sutures on the skin. These patients come back to the office for makeup and a shampoo. We don't remove sutures. All the preauricular incisions and temporal hairline incisions are closed with dermabone. And you can see the results. Dean Torium and I wrote extensively on this, and the results are fairly good. And a year later, they're the same as your best suture closure. Both retroauricular use plain gut, 5-0 absorbable plain gut, so these patients have no suture removed. And again, these techniques, regardless what you do endoscopic or not, open or not, surgical or not, will provide good results consistently as long as you have this team approach, and that's why I call it a package. For example, this is a mid-50s, 54, 55-year-old lady who underwent endoscopic brow lift, mid-face lift, neck treated just with platismin and skin, laser resurfacing, and a continuing aggressive skincare. And you see at 5 years, she's still doing very well. Again, keep in mind, I work in Utah, very dry, very high altitude. It's terrible for the skin, so we don't have the nice humid weather that you have in some other parts of the country. But you can see the results are persistent, and because of this global approach to the face. 75-year-old patient came in for her secondary facelift. I opened her through a facelift. I couldn't find any tissue that I could elevate with her SMAS, so I went back to the forehead and did a mid-face lift, lifting all the tissue up and corrected her neck through a traditional cemento incision and platismal repair. Again, aggressive skincare, aggressive IPL treatments. You can see the quality of the skin and how much improvement at 5 years. So in summary, the surgical procedures I do as part of this aesthetic package include short incisions, include limited undermining, especially when I use the scope, Endotyne devices. And by the way, I have no conflicts of interest. I don't get anything from any of these companies. I avoid the intraoral incision. I avoid the eyelid incision, except if I have some extra skin in the lower eyelid. I'll do a skin-only excision. Periocular lasers very often, and tissue glues. That's my surgical approach to minimize, to improve postoperative recovery. So the third and final component of this package is the postoperative treatment that involves early lymphatic drainage massage. I encourage you to try this. It helps a lot of the swelling, helps the bruising. More than that, it allows that patient at 48 hours to spend an hour with one of your employees and receive all that attention that you and I don't have time to give. And a lot of times that patient will share things. For example, I'm not doing well, my pain medication is not working. That massage therapist will immediately talk to my nurse. So you get a lot from that relationship with patients. We also got a dead corner in our office, and we're using now Jen Irondale makeup. I'm sure Dr. Graff can expand on that, but it's a terrific line of products for camouflage makeup. So at 48 hours, this patient come in, 72 hours, this patient come in, they get lymphatic massage, they get makeup, and at 72 hours, they look okay. They can go out and they don't look beat up and have to hide it at home. This is a good example of a patient that came in for endoscopic and mid-face, endoscopic brow and mid-face. I did her surgery Monday morning. At 5 days on Friday afternoon, she came in, did her makeup using some of these products, and she was ready to go to a social, to a party. And that's unusual with the open technique. So I think that combining all these approaches, you can get those patients back early. So finally, how do we address this with the staff? We take somebody like this one, and we analyze her with the nurse and the medical estheticians. We look at her hair, we look at her skin, brow position, eyes, mid-face, lips. What are the things we can do surgically and non-surgically to improve this individual? And there are a lot of things we can do surgically, but there are a lot of things you can do non-surgically, and patients really like this global approach. So, in her case, we did an endoscopic brow, endoscopic mid-face, fillers for her lips, and nasolabial folds, and an aggressive makeup program. But you can also take somebody in their mid-60s and do the same analysis. Look at hair issues, skin issues, brow, eyes, mid-face, lower face, skin, pigmentation, all these issues that we are not trained to do, we're not trained to recognize. That's why I surround myself with this very professional people. And you can improve these individuals tremendously and improve their self-esteem. Again, it's not a scientific photo, but it just shows you how satisfied these patients are, and that's how they will leave the office. So I encourage you to look into this and offer to your patients. The last and final quick topic, I have 5 minutes here, is legal issues, and I don't want to. This is a big issue, and I want you to be very careful when you implement these techniques. The supervision and staffing is a big issue. It's regulated from state to state, so be sure you look at your state regulations before you start doing this. In my opinion, plastic surgeons should do the evaluation, make the diagnosis, and the entire treatment plan, and not delegate. The plastic surgeon is responsible for all the treatments. The plastic surgeon needs to determine his or her availability during treatments. Be sure you post your hours. If you have a facility like this, be sure you post your hours. Be sure your staff and the patients know you are in the building. Many times I'm in my office answering emails from Dr. Nahai, and they don't know I'm there, and they will cancel a consultation or something. So be sure you're there and document it. And most importantly, review the guiding principles on non-physicians approved by ASPS and ASAPS in October 2006. This is a very good document. We spent a long time working on this and for your benefit. Products, if you have products in your office, and many of us have, be sure that you understand the product liability issues. Counsel clients on proper use of products and warn of the risk if the products are not used properly. Be sure your staff is telling your clients about the products and how to use them and the possible complications. Buy good, solid product liability insurance, because if somebody gets hurt down the line, ultimately is your responsibility. And be careful in what you sell. It's your responsibility. It's you are in charge. It's your place. How do you avoid disaster? Good sense, good common sense. Get consent forms. Every single treatment, the patient needs to sign a consent form. They're available. You can call Jason, you can call me. We have these things. Many of us have this. Know your state laws. It's a lot different to practice in Chicago than it is in Salt Lake City. So don't take this lecture and start doing this tomorrow without checking your state laws. Post your hours. Review your medical malpractice insurance. There's a separate insurance for a medical spa. There's a separate insurance for products. So, be sure you're present, train, and supervise your staff. I like to run it like an operating room. I tried, when I first opened, I got into this kind of salon kind of mentality, very loose, very nice, very relaxed, and I wasn't happy. And then I changed it, started running like an operating room, and everybody got in line. So I think it's very important because ultimately it is your practice, it's your name, and it's your reputation, and these are your patients. Thank you very much.
Let's look at what is happening. Jason showed some of these, and I'm going to repeat them and show them in graphic form. If we look up at the top there, you can see that things have sort of flattened, and they flattened there too, so we're hopeful that this will take off again. But if we look at the top 5 cosmetic surgeries in women, with the exception of blepharoplasty, there's no facial aesthetic procedure there. And we spent a tremendous amount of our time yesterday talking about facelifts. Facelift is number 7, and there's only 138,000 of them. And brow lifts are in the 50,000 range and don't even make the top 10. And then let's look again at liposuction as the top surgical procedure, and then look at Botox, look at that again, and then we're also going to put that into perspective. Close to 500,000, well over 3 million. So things are changing, as Jason pointed out, and he stimulated me to sit back there and say, well, what will it be like in 2014 and 2017? The only facial procedure in the top 5 is blepharoplasty. Now, if we look at what's happened between 97 and 2006, look at that 9-fold growth there, most of it in the past few years. And if we look at facelifts, look what's happening. Is this the beginning of a downtrend? And I said that in 2005, and it probably is. Look at what's happening to brow lifts, 1997, 2006. We're doing less than we did 10 years ago. And I alluded to that yesterday on one of the panels. Why? Because Botox is so effective. Look at what Botox is doing there in the green, and brow lift, all the things that we do surgically and spend all our time and effort, confuse each other. This comes as no surprise. 80% of the patients we operate on are Caucasian, the other minorities equally distributed. This was very interesting to me that 23% of us are still doing these procedures in a hospital, but most are doing these in our office-based facilities. This is a little out of order, but I just want you to look at that right there. Once we forget about this group here, you get over 35, what's the most common procedure they're having? They're having needles. Now let's look at the money involved here. Non-surgical procedures, 4.2 billion, surgical procedures, 8.2. So that makes a lot of sense, but let's break it down, the economics of it all. Let's break it down. Average revenue per procedure, close to 4,000 for the surgical procedure, 451 for the needle. Let's look at time and liability issues and decide where are we better off. And the final thing I've included there from the ASAP statistics is that a large number of us do not work with a Medi-Spa, whether it be in our own practice or across town. Now, if those numbers weren't enough for us to be concerned, look who else wants a piece of the pie. We've already seen this. This is the American Academy of Cosmetic Gynecologists, and the point that they make, and the point that Renato was making in his talk, they say that there'll be a paradigm shift, that women are our patients. They have to walk into our offices, whereas we, the rest, meaning you and I, have to advertise to get the women into our offices. It's injectables today, surgery tomorrow, and our eyes are wide open to that. So this, Renato alluded to this, Physicians Coalition for Injectable Safety, ASAPS, Oculoplastic Society, Facial Plastics, and originally it included ASDS, American Society for Dermatologic Surgery. They pulled out. ASPS elected to stay on the sidelines and see where this project is going. If you haven't been to the website, please go to the website. Please refer your patients to it, injectablesafety.org. This was initiated, basically a partnership originally between the four societies and the manufacturers to bring to the attention of the public fake injectables, imported injectables. But that project has now expanded into safety as to who should be doing the injecting, what is their training, and where the injections should take place. And this is why the ASDS dropped out, because they feel very strongly that injectables should only be performed by the physician, not by a nurse or physician extender. So what does the needle offer? What are the advantages of the needle? It's an office procedure. Botox takes 2 days, but we still call it an immediate result. There's no downtime, much less expensive, and the complications are less severe, and at least with the injectables that we have available, the complications are less likely to be permanent. So needle and the knife, safety and efficacy, patient satisfaction, longevity, and cost are the issues that we look at. Basically, everything is temporary. Even those fancy facelifts we talked about yesterday are temporary. So it's all relative, and as one of my colleagues from Brazil told me before, the only thing permanent about a facelift are the complications. So let's look at the impact on my practice. This is 2003. I haven't dared go back and look at what's happened since then. This is a typical Monday morning when I see patients, new patient appointments. The red circles are on the injectables. The blues says facelift consult. Everything else has been blotted out to protect the innocent and to be in keeping with HIPAA regulations. I dare say if I went and did this tomorrow, December 3rd, I would see lots more reds and have to go to page 2 before I saw a blue. So what effect had, 5 new consults, 2 of them were facelifts, 3 were for toxins and fillers. But what it's done to the bottom line, and it continues to grow, is that on a monthly basis, the injectables bring into my personal practice, not into Pace's plastic surgery, the equivalent of 1 to 2 extra facelifts. Now, as Gil pointed out, they're also taking away probably more facelifts than they're bringing in. So the impact on the number of patients, impact on the bottom line, at least 1 to 1.5 more facelifts a month in terms of the revenue generated. I prefer by far to operate rather than inject, not for financial considerations, but for the results. Fillers and toxins are not a substitute for an operation, but a lot of patients have been told so and believe it. The soft tissue fillers, we talk about them as autologous, biologic, synthetic. These are the ideal the characteristics of the ideal filler. Not even fat fits in there. And I'm going to tell you, all the current available fillers fall very short of being belonging in each of those groups. But there's one thing I want to point out here, and that's reversible, and I think that's probably very important. Although we don't have reversible, at least we have some that are semi-permanent rather than permanent. Autologous fillers, most of these have now gone by the wayside. Fat grafting has risen to the top and is obviously everyone's choice as an autologous filler. This was circa 2003, what was available in this country and internationally. Several of these have also gone by the wayside, so I won't spend time on them. Again, 2003, several of these have also gone by the wayside. Gore no longer makes any materials for implantation. The reason I included all that is the field just keeps changing. There's steadily increased number of synthetic fillers are available all over the world. The same material is called something different in each country. Your patients, through the magazines, through the TV, read about these. They're told that they have magical properties, and they'll all come in asking, or they'll call your office and say, do you inject amazing gel? So the number and variety is impressive, and I think we at least have to be aware of what's out there. Now, silicone is FDA approved for treating detached retina, and it is being used off-date label as a dermal filler. I've had some experience taking care of patients who had liquid silicone injected deep to the skin, putting free flaps on their faces, and that was a disaster. But the experience with silicone 1000 is that maybe it behaves differently when it's put in the dermis than it did when it was put in the soft tissues. Bioplastic is solid silicone particles in a carrier that has been injected. That's permanent, so is the silicone permanent. And personally, one of the things that I tell my patients is that I shy away from permanent fillers. These are some others from 2003. Again, Aquamid, an amazing gel. Let's talk a little about the HAs that are by far the most popular. The first was Restylane. It was FDA approved December of 2003. Gosh, can you believe 4 years has already gone by? The concentration is 20 milligrams per mil and particle size is 400 microns. Does that matter? Yes, it does, and you'll find out why in a minute. There was a paper in the dermatology literature reporting that Restylane, by stretching fibroblasts, stimulated de novo collagen production whilst inhibiting the breakdown of existing collagen. So this is something exciting, and obviously the manufacturer promotes this. Juvederm was approved in June of 2006. It has a slightly higher concentration of HA, but it's randomly shaped particles as opposed to the uniform particles of Restylane, and there's additional cross-linking, and the manufacturer claims that this makes it a lot easier to inject. And they also, I'm very intrigued by this claim that Allergan made earlier this year. With one touch-up, it may last a year. Now, Restylane versus Juvederm. The particles are uniform shaped, Juvederm randomly shaped, believed to contribute to the gel-like consistency, easier to inject, and even claims that there's less bruising. And by the way, you saw my list of disclosures. I have no, I don't have any horse in this race. To me, it's this. Restylane and Juvederm is Mercedes, BMW, Boeing, Airbus, Coke, Pepsi, and Delta versus American, and I guess all of you know where I live and where that company is headquartered. So my favorites are there on the left, and my apologies to my European colleagues. Now, FDA approved Juvederm Ultra and Juvederm Ultra Plus all at the same time. And Ultra Plus has larger particle size, more cross-linking, and it's designed for deeper injections and designed really for volume rather than wrinkles. Perlane was approved in January of this year. You can see it's much, much larger particles compared to Restylane. Concentration is the same, and again, it's thicker, it's for volume, and it has to be injected deeper. Now, the larger the particles means that there's less surface area for the HA to be degraded. The way these HAs are degraded is something that's called volumetric degradation. As they're being degraded, they pull in water, so they keep their volume for much, much longer. And the larger the molecule, the slower the degradation, and the longer it'll last in the tissues. Coming soon, and this you need to be aware of. Evolence is in Europe. It's porcine collagen, which in Europe, at least, the claims are that it lasts for about a year. And perhaps Alex or Patrick will comment on that. Mentor has Purigen undergoing tests in this country. Reloxin with Medicis is basically what's been in Europe. Dysport, and the claim is that Dysport diffuses a little better than Botox. And Mentor is also working on Puritox. So this is what's on the horizon. Radius, formerly Radiance, is calcium hydroxyapatite mixed with methylcellulose. The caveats are it's semi-permanent, there's risk of granuloma, inject it deep, and don't inject it into the lips. Collagen, human-derived collagen, Cosmoderm, Cosmoplast. I haven't used it, and I know some people keep it there and say, well, it's good if you just need something quick or overnight. Artifil, formerly known as Articol, the PMMA microspheres. Allergy testing is required. FDA has approved it, but not for the lips. And Articol in Europe has had many, many complications. In fairness to Artifil, they say they've changed things, that the PMMA microspheres are much more even in size now, so they claim that the European experience has made Artifil safer and better. Sculptor basically is Vicryl, and it's semi-permanent. The results are gradual. They have to be repeated, and the manufacturer claims that there's actually skin tightening. Where do we use what? These are my choices for folds and creases. Again, Restylane, Juvederm, and then the deeper you go, those others. Lips, Restylane and Juvederm Ultra. Periorbital, Restylane, Juvederm Ultra, and for volume, the heavier stuff. There's a relationship between the size of the molecules in the injection site, and this is also related to viscosity. So the larger and the more viscous, the deeper that we have to inject them. This is the dermal injection. This is the deep to the dermis, and then we can look at the layering, laking, and pushing the lakes down with your fingers. Layering is using one product deep, another product right under the skin, and this is very good. Now, what are the limitations, the results, the cost, and the cumulative cost? The results are very much injector-dependent. They never approach a surgical procedure, and I'm going to finish with this one. The limitations in terms of cost is the ceiling. I have found, at least in the Atlanta area, the ceiling seems to be around $2,000. They won't bat an eye. They come in, pay for Botox and Restylane. And fillers and toxins do add up, but there seems to be a ceiling. They're willing to come back 6-7 months later, do the same thing again, rather than multiply that 2,000 by a factor of 10 or 15 and have a facelift. Thank you.
Just before we get into the questions and answers, I want to introduce Dr. Jeanette Graff, dermatologist from New York, faculty at NYU, and a terrific speaker on fillers and cosmeceuticals. So you're very lucky to have her here today. So we all have different setups, and I think it's a good opportunity for you to have questions. And as you come to the microphones, I just want to ask each one of us, one of our speakers, how do you practice cosmetic medicine? Let's start with you, Jeanette. Do you have a medical spa? Do you do in your office?
I work in my office. I'm a dermatologist, so my perspective is different. My patients come to me in the perspective of a dermatologist because they don't want downtime, they don't want anything invasive. Now, there is no substitute for anything. If somebody needs surgery, they need surgery. However, the fillers and all of the other ancillary procedures that we do that have become so popular and have really improved really just enhance each other. So the number one, I think that medi-spas are terrific. It is a huge, huge undertaking. In my practice, I have an esthetician who I've known for many years, who I constantly send for training, who I constantly send for education. She does hair removal, she does IPL, she does amazing facials. I think it's important to have someone in your office, especially as an esthetician, who not only does something that makes a difference, and we use really excellent professional products and machines and lymphatic drainage, but it has to be an experience. It has to be something that is so pampering and so up and beyond that patients want to come back for it. Like you, I also have that beautiful Jane Iredale display. Jane Iredale is a great makeup. Anyone who does cosmetic procedures should have makeup in their office. If patients bruise, they need to be able to cover it. I love Jane Iredale because it is a mineral makeup. It is the best one. It has an SPF of 20. It is totally preservative-free, so it is good for any and all patients to use, particularly if they've had a procedure. They see the display, they will want to play with it. They will always come back for product and skincare. And even if they don't see you for something, it is a reminder, because when they come back, they will keep coming back for product they love. So we just make it so wonderful for them to come that they do come back.
Thank you. Rod, you've always been an innovator, visionary. How are you implementing this in the residency training? I was curious to know if you're still working on a medical spa. How are you doing this in Dallas?
All our residents have an outpatient surgery rotation, so they rotate with us for two sessions, and as part of that, they come up to our clinics, and then we have a cosmetic rotation as well. So, and then we also have special sessions where we teach them how to do fillers and Botox, and then whenever they do fillers or Botox or any of that in our offices, they are supervised by a faculty. So it's none of that willy-nilly stuff. And then they spend time with our estheticians. I think you're absolutely right. The estheticians have to be just like surgeons and dermatologists. We have to be experienced. And just remember, you are only represented by your weakest link. So everybody's got to exude excellence. And your estheticians, we have two estheticians at our university office, and they've been with us for years. They know exactly. In fact, they see all my patients. They know exactly what I want, what I like. And I love Jenner. That's a good point. I mean, of course, we leave them. When they go home, they don't go home with a bruise. If they have a bruise, we cover it up. So that's part of our training program. But I think we all could do more. I mean, we so de-emphasize outpatient and non-surgical things in most residencies. It's a real problem, I think.
Thank you. The gentleman from the back microphone.
I have two questions. One, to try to maybe fill in the gap that Dr. Warwick asked the panel, anyone who has experience with Artifil, if they could just tell us. And secondly, for Dr. Saltz, what is your approach you think we should take when we go back to our communities to tastefully and professionally raise the expectations of the patients that some providers are different than others? A lot of us do a lot of reconstruction, and many of our colleagues who are referral doctors in internal medicine, family practice, who are very happy to send me a breast reduction or a skin cancer, are also doing laser services in their office. And any thoughts on how to do that?
So do you want to address the Artifil question? Right.
Well, I don't. I mean, it's nothing against it. I just personally just don't think it's a good thing to use a permanent filler in the face. I guess I've been biased over the years of seeing a lot of these long-term silicone patients, and so I don't have experience. I think Ian Jackson's got some good experience with long-term fillers, but I just don't think that they age well. And I don't know if does anybody else on the panel inject filler Artifil?
We've done a little bit over the last couple of months. Just getting into it.
Over the last couple of months?
The last few months. Using use for men. I think some of the men who come in with a little thicker skin probably can get away with it a little bit better without some of the complications. I'm definitely afraid of thin-skinned women. But the guys really want to come in, they want a permanent filler, they don't want to come back, so I think it's sort of a different group.
Jeanette, do you have any experience?
I personally tend to shy away from permanent fillers. The good news about the fillers we have is they last longer, and the good news is that they're not permanent. So I also have seen a lot of long-term. With filler, you have to find the one that you are most comfortable injecting and use what you feel comfortable injecting. I personally would rather not use a permanent filler. We don't know how it is going to age with the face 10 years down the road, 15 years down the road.
To answer your question, the two you saw the work that the two societies are doing, under their leadership, and I think that's wonderful. But it's really down to our communities to work. I'll tell you what I'm doing. What we are doing in Utah is working with the State Plastic Surgery Society. We're actually going to start promoting this in the local newspapers as board-certified surgeons. And I think a lot of the information, a lot of the learning came from the studies that I presented this morning. So you need to get together and have an active voice.
I think when I say core specialties doing the non-invasive things like fillers and Botox. I think it's dermatology, plastic surgery, and ENT. We have to work together. To be honest with you, we all learn from them. I learned how to do fillers. Before we introduced it, I learned from the Carruthers and Arnie Klein and others like that. So we have to work with dermatology. When I'm talking about people the spas and things like that. But we work with our core specialties. I have no problems with that. And I think that even highly trained nurse practitioners in certain states, that's great. And if you can oversee their patients, I think that's fine to do too. I think everything's got to be under the control eventually of you as a physician. But I think where we have problems if the OB-GYN is delivering the baby, then also doing the Botox and the fillers, or the dentist cleans your teeth, he does your Botox. I have a little problem with that.
Forward, you want to comment on that?
I was just to reiterate that there is progress, but progress is slow. I'm sure those of you in Florida will correct me when I say that the time, truth in medical education, when you advertise, when people come into your office, you have to tell them what your background is. We have to do a lot. Organized plastic surgery, the PSEC is spending millions spreading out the word, but it'll be slow. I see a European at the podium. The French and the Germans have been able, in fact, the Germans have been able to get regulations that surgery to liposuction by surgeons only. So there is progress, but it'll be very slow. I spent a lot of time talking about the Injectable Safety Coalition. So these are the things that are going to happen. In the meantime, for practical reasons, you have to make individual decisions in terms of how you deal with those internists and whether you want to continue getting their surgical referrals.
I have two remarks from Europe and one question for the panelists. Considering the botulinum toxin, I think it's a problem indeed that there's only one company selling Botox in the United States. In Europe, we have Dysport, which is actually just as good, and I think perhaps even a little better than the Allergan product, and it's sold at almost the same price. It's a little cheaper, actually. So I hope that it will eventually come to the United States. Another thing concerning the lips, Restylane has come up with a new product called Restylane Lip, which is like Perlane, and it's a little more supple. And I started using it about a year ago, and it's quite nice, so it might help. The question that I have for the panelists, especially for the plastic surgical panelists, how do you manage to keep on doing all these patients for Botox and fillers, because they come back, and I found that after a few years my practice was clotted with Botox scheduled patients, and I saw my time for seeing new surgical patients going down and down and down, and I had to take in a physician to help me doing the Botox. I think for a plastic surgeon it's a difficult problem to keep on doing all these fillers and Botox patients.
Take it from here, Jason.
That's the problem that we run into. And I operate 3 full days, and I see patients on 2 days, and we might see 50, 60 patients on a patient day with 10 new consults and fillers and all the follow-ups. I try to hand off what I can to my PA, but we block out time, and sometimes I'll block out some evenings for some Botox and fillers, but we actually make a concerted effort with our scheduling program to block out certain times for last-minute fillers and last-minute surgical appointments. So we try to really plan that out so that we do have a balanced schedule.
Forward.
We have 2 nurse injectors in our practice. One of them is my first assistant, and she is the best. Every time we operate, I show her the muscles. She knows where the DAO is, more than probably most people in this room, because in a facelift, I show it to her. She does it. She has her own time to do it, and when I'm out of town, she runs the Botox clinic for me. But what we insist on is that she cannot inject anyone unless one of us is in the practice, and our practice is all the same place, the operating room, and she cannot inject a new patient. The new patient has to have a consultation with me, has to have a full history dictated, has to have the informed consent form signed with me around, and then for follow-up and further injections, she does it. And in the state of Georgia right now, there are no regulations. And so just my saying that she's trained, and my telling the patients that she's trained, and I trust her, and your choice is to come back to me and to her, most of them choose her because she has a lot more time. Like you, I like to inject, go next door to see the new facelift consult, but she has a lot more time to spend with them.
It becomes a little more challenging, but I think it all comes down to patient. Office efficiency. You really have to have an efficient office. I'm only in the office 2 half days a week, so my nurses, every one of the Botox and filler patients, they're already kind of prepped and draped by the time I get in there. So I can be in and out of a Botox and a repeat Botox in a few minutes. A new one takes a little longer, but they've got photos and signed consents, everything's done. If they're like, we use ice rollers on about 60% of my patients, and then there's a few that want topical. So all that's done. So you got to rock and roll, and you got to be in synchrony. So like when you inject Botox, you're in and out. But when you inject fillers, I localize them, and I come back and see a few other patients, and we have 6 or 8 exam rooms to see patients. So it's really efficiency and how good your staff is. It helps me a lot. And I inject all my patients on our site.
Renato, even though the question was addressed to the plastic surgeons, I think Jeanette should make a comment, because one of her major societies is the one who we hope temporarily pulled out of the Injectable Safety Alliance, because they insist that injectables by physicians only. So would you comment on that? I hope I'm not putting you on the spot.
No, because personally I don't agree with that. I have had the opportunity to train some of the derm PAs are some of the most fabulous, dedicated people I've seen. So if they're well trained, and that's really the key. My practice is different. I don't go into the OR. I understand most of my colleagues and friends who are plastic surgeons want to operate. So you do need that ancillary staff.
I personally do the first treatment myself. I set up a schedule, see the patient after 3 weeks, and then pass it on to a physician who's not a surgeon, but who's continuing.
Thank you.
When we look at a youthful face, we're looking at a face that is full, not fat, but full. And, a lot of that is the mid-face. When we look at aging, now I'm a dermatologist, I have a different kind of practice. So I do focus a lot on fillers. And as I said, when someone needs surgery, they need surgery. There is no substitute. But it definitely can make a youthful enhancement. And when you look at a balloon the day of a party, and it's nice and fully taut, 2 weeks later, there's a uniform loss of volume to that balloon. So we fill the face uniformly. And as we continue to age, there's a continued loss of volume everywhere. So it's not only in the mid-face, but it's also in the forehead. And I'm actually using less and less Botox in the forehead. And I've begun using Perlane to fill that volume And again, here's another picture of what happens. There's a downward descent of the malar wad, the zygomaticus major. So we look at the mid-face. We look at how the face ages. First of all, we see a dropping of the forehead. We see a dropping increase from the lower lid to the soft tissue interface. There is a volume loss, subcutaneous, and deepening of the nasolabial fold. So when injectables come out and they say, oh, well, this is for the nasolabial fold, that to me, and this is the problem with FDA testing, is this is really probably the least rewarding place to evaluate the efficacy of a filler, since the reason you have the deep nasolabial fold is because you have mid-volume loss. So the manifestations of aging, you see prominence of the nasolabial folds, a deepening of the groove, ptosis of the commissure, thinning of the lips, you see a flattening and lengthening of the upper lip, atrophy, depression of the prejowl region, and so on and so forth. Aging is not due to one thing. We have to attack it from all sides. I'm going to be giving a skincare talk a little bit later on. I'm going to make it really simple so everyone can do it, but you need to address the skin. If you just address one thing, it is really not going to do it for you. We're going to talk about fillers. Now, what's happened in the past few years is we've seen a dramatic increase of approved filler products. There's permanent versus non-permanent fillers. I shy away from permanent fillers because I don't know how they're going to age with patients, different sources, various risk benefits, and a wide range of applications. And my only piece of advice is find 1 or 2 or 3 fillers that you feel comfortable using and get really good at them. You don't have to use every filler. And that's pretty much what I've done. I don't use any of these 3 listed. I just list them because they are in the collagen family. There's fashion, Symetra. Isologin is currently in a clinical trial. I think it's been in clinical trials since I've been in practice. But basically, it's harvesting fibroblasts, injecting them with the hope that there's going to be some collagen production. It is not FDA approved, but the collagen family of products, I almost never used Zyderm and rarely, if ever, use Cosmetic. If I want to numb the patient, I will use an anesthetic without having to charge them $500. Zyplast, I have 1 patient that gets Zyplast now, and that's cross-linked bovine collagen, which requires a skin test. I have 2 patients who are afraid of using anything but Cosmoplast right now, and that's the reason I do it. It is the human equivalent of Zyplast that doesn't require a skin test. And now we come to the hyaluronic acid-based products, only one of which I use, and that's Restylane here. Restylane was, of course, one of the first hyaluronic acid product to be approved here. It is 20 milligrams per ml, and it is very small percentage of which is cross-linked. Hyloform, of course, was from Rooster Combs, and Captique was the answer until Juvederm came. But there's Juvederm Ultra and Juvederm Ultra Plus. Personally, I've had more syringes explode on me with Juvederm than any of the other products, and it is a 0.7 cc syringe as opposed to a 1 cc syringe. It has a very nice way of injecting when it doesn't explode on me. However, it is highly cross-linked, though. How much cross-linking it is not really known. Of all the hyaluronic acid products, Perlane is the one that I use the most. I use it in lips, I use it in brows, in foreheads, glabellar regions. I use it to correct nasal deformities. When I'm using a hyaluronic acid product, that is the one that I most frequently use. I want to talk a little bit about cross-linking, and I mean very little. If you were to inject hyaluronic acid by itself, it will clear out within 24 to 48 hours. By cross-linking, which is stabilizing it, it increases the length of time that it is going to stay in the tissue. However, ideally, you want a smaller degree of cross-linking to have greater tissue compatibility. If you look at where she has aged before treatment, every single place this has been injected, the cheeks, the brows, the tear troughs, the lips, the marionette, and the prejowl sulcus. The volume here is 7 mLs. Now, obviously, we don't inject 7 mLs. The most I ever did on a patient at one time, which was not a paying patient, it was for a demonstration because no one can pay for that up front, was 8 mLs because the swelling that occurs is so great that they do have to come back. Unlike the other speakers, there is no ceiling for filler. They have to come back until their correction is made, and then there will be maintenance that will not be as much as the correction. So I always underpromise and overperform. However, you have to give them very realistic expectations. People who come in and want a permanent filler, of course they want a permanent change because everyone wants a magic bullet. It doesn't exist. I like Restylane in the tear troughs. Just remember that when you are putting it in the tear trough, and you need very little volume, like 0.4 mLs on one side, 0.6 on the other. If you stay medially, this is one of the only places that I antegrade inject. That means pushing the material in, advancing the material before the syringe, you get less bruising, but make sure that you are going along the bone. This is not a superficial injection. If you do inject it too superficially, the patient will have swelling and lumps. This is one of my patients who was in a car accident when she was 16, had a really good cartilage graft done about 15 years ago, which since then, like the rest of the face, kind of fell. And every time she looked in the mirror, this is what she saw. You can only do so much on a nose. A nose is a little tiny piece of bone with cartilage, and you can only touch it so many times. This is great whether you choose Restylane, whether you choose Perlane, whether you choose Radius. The nose really responds beautifully to filling, and I might say that instead, when I treat the glabellar area with filler, it starts here, and I inject volume into this area because we want to make the nasal bridge more prominent, because that actually will make the nose look smaller. Radius I love. It is ideal for the nasolabial folds, the marionette lines, the perioral area, the malar area. I use a Bexa luer lock, double luer lock mechanism, and I add 0.2 mLs of 2% lidocaine and just kind of swish it back and forth. It's DEXA. You don't have to use any kind of regional block. In fact, there's only a couple of patients that I do regionally block for anything. I love doing intraoral Restylane for the malar area, which involves just putting some hurricane or topical anesthetic into the buccal mucosa and injecting directly above the buccal mucosa. It really has a very nice result, and it's simple to do. I love Sculptra. It is a good filler. It is not immediate gratification. It's delayed. It takes 3 months for it to work. You are forming a scaffold of polylactic acid, which is going to, over 3 months, build collagen. It looks great immediately. This is a patient who's got a tiny face. My favorite places for injecting Sculptra, she already had 2 vials 3 months before, and I put another 2 in. And I love doing it in the temples. I do it in the orbital area. I do it in the malar area and the jawline, and that is immediately after. So it is really a nice product. She is not going to look like this in 2 months. This is swelling, it goes down, and then you got to wait. How many treatments are they going to need? Well, they say 2 treatments will give you a 25% correction. So this is one of those injectables where the longer you wait, the better. And as you can see, it can give a very nice, very natural result. Artefill I don't use. Again, it's polymethyl methacrylate microspheres. They're finer than the article. It should only be injected in the nasolabial folds. This requires a skin test. It is FDA approved. I'm just not going to use it. As I feel that way about silicone as well. I have colleagues who love silicone, and they love using it, and they would have it themselves. I don't have the experience. I have seen reactions. It does move, and later on, even in acne scars, it tends to move. Silicon 1000 is approved for retinal reattachment. Silskin 1000 is actually undergoing clinical trials right now, and the Dow product, or similar to the Dow product, is by Vicomed in Germany, which is a low viscosity fluid. Polyacrylamide gels are another non-FDA approved substance that kind of behave more like the silicones. Again, there is insufficient testing, and these types of products have a higher incidence of late complications. Evolins kind of interests me because it's a pig material. It's supposedly it has natural sugars which form stronger bonds in the collagen, and it lasts up to 12 months. However, I'd like to see that it hasn't been clinically proven. The other types of porcine collagens, permacol, fibroquel. So I'm going to conclude by saying aging of the face is multifactorial. You need to have certain things done, and in addition to filling wrinkles and folds, as most physicians are doing, you want to increase the volume for a youthful appearance, and with ongoing FDA approval of products, we have a great future here. Thank you.
So let me share with you just this little technique which I like very much, and has been a great addition to my practice. So I sometimes demonstrate how we inject the Restylane products. I have no financial interest in the company. So what is the tear trough? Basically, it's depression centered over the medial orbital rim. So superiorly, there's cheek skin, fat, and SUV. Inferiorly, superiorly, there's the orbicularis muscle, and sometimes there's protruding fat. The basic thing is that there is very thin skin, very little or none subcutaneous fat in that area. That sometimes exists in youth, but like many things, it becomes worse with aging. There are several ways to correct the tear trough. And one of them is the surgical way to redrape the orbital fat. It has been magnificently described by Hammerand and Roll. The downsides are that it requires surgery. You really need to completely release the medial orbicularis insertion to get the fat into the tear trough. It's sometimes hard to feel the medial and the lateral end of the trough because you sometimes don't have enough fats to redrape. And obviously, it's a technique which is not completely complications-free. Lipofilling, we're doing more and more of it. We love it. Sometimes patients don't like it because it's a surgical procedure. There definitely is a learning curve as to the amount of fat that you want to inject, where you want to inject it. Do you have to overcorrect how much, in which level you are going to place it? I think you should place it deeply, and as Sid told us, the superficial plane is an advanced user plane, so I would recommend it to start it. And there is this issue of blindness with any injectable that you inject around the orbit. And then the fillers, of course, and there's a vast range of available products, especially in Europe. I never use permanent fillers because I think they might be very appealing, but they can lead to permanent problems, so I only use non-permanent products. And there again, you have different options in which level you're going to use it, and there's the theoretical possibility of blindness. Now, what is Perlane? It's been around in Europe for several years. I've been using it for 5 or 6 years now. It's Nasha which stands for non-animal stabilized hyaluronic acid. It's basically the same thing as Restylane. It has the same concentration of Nasha gel, but the particle size is larger, and that's why it's a little more coarse, and it stays longer. It's recently been FDA approved for nasolabial fold correction. It's advised to be injected with a 27 gauge needle. You can inject it through a thinner needle. Waffle School uses it like that. I like to have a comfortable injection, not to have to push too hard of a plunger. And it's typically used for correction of deeper wrinkles and folds and for lip augmentation. Disability, which is reported 6 to 12 months, as you will see, is in this specific situation sometimes even longer. So I put a little anesthesia at the upper end where the branches of the infraorbital nerve come, and at the zygomatico-frontal nerve, so that I numb the whole inferior orbital rim. You really need very little local anesthetic to do that. And then I inject with several punctures. Typically, I never inject more than 0.1 milliliter per injection, and that's one of the reasons for that is that theoretically 0.1 milliliter is the amount of product that you would need to fill the column between an artery and the central retinal artery. So if you stay below that, theoretically, that should keep you in the safe zone. So I make several punctures and inject while I'm moving the needle, and then afterwards it can be molded, which is the level where I inject. So it's on the bone. Here's the orbicularis muscle, and you have to make sure that you put it at the most prominent part of the orbital rim, because if you inject the product right there, you're going to lose a lot of product, and basically nothing's going to happen. So what you do is you put in the needle, and you sort of walk along the orbital rim until you're sure that you're at the most prominent part, and there you inject the product, and just as much as you need. All right. So most of the time I do a little digital molding afterwards, so that I'm sure that the product is evenly distributed. This is a little video just to demonstrate. In the medial part of the orbit, I aspirate a little bit, and so I'm sure that I'm on the bone without hitting it too hard, because then you make your needle blunt. And then I inject, and you see that while injecting, the needle is constantly in motion. It never stays still at the same spot, and you inject small amounts of Perlane, and you gradually walk along the orbital rim as you correct the orbital, the periorbital depression. And you can treat as well the tear trough as the more lateral parts of the orbit, and it's actually quite easy. You just have to go in and do it just by small incremental amounts. What you see is what you get. If you haven't injected too much of local anesthetic, you perfectly see what you're going to obtain at the end of the treatment. So this is the situation immediately after the treatment. There's some bruising, as you can see, but you can perfectly see the correction that you have obtained, and immediately you see that the shadows have disappeared. And this is going to last, in my hands, it lasts at least 12 months in this location, because you put it on the bone, it's absolutely immobile, and I can really promise my patient that it will last for a year, and most of the cases it lasts a year and a half, and I have one patient who's had 22 months of of correction with one treatment. So obviously you need good lighting. I like to have my patient nearly upright to have the natural situation. I try to aspirate before injecting. Small amounts per puncture I think is one of the key points to keep it safe and keep the needle moving while you're injecting. Obviously there are several other ways to treat the tear trough, and Dr. Graff has shown one. Michael Payne of New York uses Restylane in high form. He uses it in more superficial plane. He injects multiple passes. I haven't tried it like that. I'm not sure if you really inject it superficially that you might stiffen the lower eyelid, but I mean there are several ways to skin a cat. So a few clinical examples. This is one of my earliest patients. Actually, I treated her with Restylane at that time, and she was very happy. She's had the treatment redone several times since then with Berlane. And with Restylane alone, it stayed stable for 7 months. So afterwards, I started treating her with Berlane. This is another patient, and basically the treatment that I did is make several injections, inject small amounts of Berlane along the orbital rim, and this is the results that we obtained. Another patient who specifically only wanted correction of the medial part of her orbital rim. She didn't want anything to be done laterally. So there I injected about 0.35 cc's with an immediate correction of the medial tear trough. And in the lateral view, most of the time you see a very nice blending of the lid-cheek junction, which is a constant and very easily reproducible phenomenon. This is immediately after the injection. This is upon control. I like to see my patient 3 or 4 weeks afterwards. Sometimes they need a little touch-up, and I offer that touch-up for free. Here again, you see a good blending of the lid-cheek junction, and this is 3 or 4 weeks after injection. This is a young lady, and the tear trough, as I said, is not a specific feature of aging. As you can see, she's had it. She's 19 years old, and you can get a very nice improvement of her overall appearance. In the cases that I treated, I got complete correction upon the first treatment in 93%. It's very stable. I can promise at least a year. There is very little downtime, less than 24 hours, just a little bruising in 75% of the cases. There are some minor ecchymosis in a few patients, minor irregularities, which can be corrected just by digital pressure. There are no major complications, and I see a very high patient satisfaction. Obviously, the pigmentation, which is sometimes a dermal problem, is not always corrected. I think you need local anesthesia to have a patient quiet and relax and not withdrawing upon injection. It's not permanent, but it's simple, it's cost-effective, it's safe, it's absolutely immobile when you put it on the bone. It's a well-known product, and the patients just love it.
I'm a FDA, the GFX is FDA approved for ablating nerves in general. The representative out there will tell you himself that they do not have a specific indication for aesthetic application yet. I'm a clinical investigator for ACI who makes GFX. I have no compensation, no financial interest whatsoever with them. Nerve ablation is not new using radiofrequency. It's been used in cardiac induction application for many, many years. It's also not new in the glabella, but the device that's being presented is new. Some of the initial questions that I've had and that get asked to me, I'm going to answer a couple of them up front so you're not wondering, does it work? Yes. Last how long? I'm not sure. Will it replace Botox? No. A little bit of background. Advanced Cosmetic Interventions is based in Denver. GFX stands for glabellar furrow relaxation. It's a nerve stimulator and radiofrequency generator on the same chip, which is kind of convenient. It's nice. You can find the nerve with a nerve stimulator. Once you find it, you run the radiofrequency. You create about a rice kernel size of ablation on the nerve. It's about the size of a rice kernel. Where are we targeting? We're looking at that frontal branch part that innervates the corrugator, that transverse part of the corrugator. I have not done this part yet, but some people are also targeting the angular nerve that innervates that more oblique aspect of the corrugator. Brief description of the procedure, and then we're going to look at a short video. Because you're looking for that stimulation of the nerve, you really should not be using, you can't use this on a patient who's had Botox within the last 3 months because then you cannot find where that nerve is activating on the corrugator. Patients, because you're using needles and sticking them for anesthesia as well, they should be off any medications that inhibit normal hemocoagulation. Then I go through informed consent with all these patients. I try and undersell this procedure a bit to my patients, not overpromise them anything. Materials you need are fairly simple: some topical anesthetic, local anesthetic, 2% lidocaine mixed with hyaluronidase. You can use low volumes, 1% with epi before you actually make the needle stick. An oral sedative is extremely helpful with these patients. RF energy does hurt. Even despite a good local block, it still hurts. And using oral sedative can be an immense help. 18-gauge needle, the probe, ice pack, gauze, gloves, skin prep, etc. This can be done after a few times in less than 20 minutes. Once you get familiar with it, you can use it in the same room that you might do a laser procedure in. This is the box, that's the pedal, this is the probe itself, comes in a sterile pack. Patients, like I mentioned, are pre-treated with oral Xanax, 0.25 milligrams. We apply topical anesthetic cream for where they're going to get their numbing shots, skin prep with some alcohol, and you'll see a supraorbital nerve, lateral nerve, and zygomatic temporal nerve block, and a little dermal wheel where the puncture site's going to be. This is some of the photos from the company itself, but you're going to put this probe through a puncture site deep to the superficial temporal fascia, run it along the nerves in the forehead until you get pressing that little stimulator button until you get activity in the corrugator, then you decrease the stimulation level on the probe so you can really hone in on exactly where that nerve is. You can see the difference between where the frontal branch goes to the frontalis muscle and where it goes to the corrugator. Once you find it, you run the RF energy, create a lesion. You can do 1 lesion, 2 lesions, 3 lesions. I'll get a little bit of that later. And this might be the approach to the angular nerve. The more perpendicular you go to the nerve, the easier it is to find it. Post-procedure icing, I have my patients just have a restful day. The rest of the day, don't go to the gym. This is not a procedure where they can necessarily have it done and then expect to go for lunch with a friend or out shopping. I have had patients go back to work without a problem, though. I just recommend acetaminophen for NSAIDs as needed. This is the patient we're going to see in the video. She's never had Botox, never had an aesthetic procedure to her face, but just wanted some reduction in her glabellar furrows. So this is about 2 minutes long. You can see first it's showing full activity of frontalis, full activity in her corrugators. This is the supraorbital nerve block. Use a 30-gauge needle, go about 3/4 of an inch deep, deliver half a cc of that 2% lidocaine with hyaluronidase. Same thing for the lacrimal nerve, same thing for the zygomatic temporal nerve. You can get a very nice numb field in the forehead and the temple with this. The idea is that you do not want to give an anesthetic directly where you're applying the energy because if you deaden that nerve, you're not going to be able to find it with a nerve stimulator. So all of your anesthetic needs to be away from that nerve that you're trying to target. Just testing her to make sure that she's adequately anesthetized. Then you're going to see the probe come in the picture in just a minute. I'm sorry, the 18-gauge needle will make just a little puncture site and a natural crease, natural crow's-foot crease in the corner. Then the probe, I've already done it deep to the superficial temporal fascia, starting up high. This is the branch from the frontal to the frontalis muscle. You see it raising her brow. I'm just applying the stimulation on that tip, walking myself down until I find that branch of the frontal that goes to the corrugator. You'll see it in a minute. The corrugator is going to go immediately and transverse. I'm getting close. Once I found my spot, I kind of prepare the patient that there's going to be some energy here. I put a little ice pack on right where that energy is going to be delivered, and look, that's success. There's a dense tetanic response in the muscle right when you deliver the energy, followed by some fibrillation. And the result's immediate. And I think I have her flex right after this energy delivery. It's about a 16 to 20 second delivery of energy. The first time it occurs, it does hurt. Patients say it's about a 6, on average about a 6 out of 10 on the pain scale with the Xanax. They just don't care as much about it. This is immediately after the energy delivered, significantly weakened. Putting a second lesion in, going a little bit more medial on the nerve, finding that spot where I get activity, applying some ice, running the energy again, and look for the dense tetanic response here. It means I'm right there. There's a dense tetanic response in the muscle. You know you're right on the nerve, and you know you're going to get a good ablation. In my experience, the ones that I've gotten that response on are my best results. The patients where I get kind of a weak or moderate tetany in the muscle, their results have not lasted as long post-operatively. Frontalis is completely intact after that ablation. And just moved on to do her other side. So this is her, again, post-op, at rest, activity at 10 weeks. There's a nice reduction there, and I tell my patients to expect 60 to 80% reduction. I cannot get 100% just targeting that frontal branch. Patients who want that 100% effect, I tell them they need Botox. Patients who want to maintain some sort of activity in their glabella, I tell them that this might be a good idea for them. Could I perhaps get 100% reduction if I targeted the angular nerve? Maybe, but I just haven't reached a comfort level going there yet. My experience, 16 patients, all underdone local plus or minus oral sedative, frontal branch ablations only. Average follow-up is still early, about 10 weeks with the photos. In reality, it's about 4 or 5 months. Haven't had any complications because this is part of a study that patients are not getting charged. Actually, on the complication part, with that supraorbital nerve block, I've had 2 temporary lidocaine effects, litosis. One of it resolved by the time the patient left the room. One of them I put 2 drops of phenylephrine in just to get them so they could drive in their car. Nothing permanent. This was the first patient I did. She got a nice effect on the left side, which was the second side that I did. The right side, I didn't get as good of effect. It was my first time. I wasn't positive about how to use the simulator, what to look for in the muscle. On the second side, I was a little bit more confident about it. She's actually 5 months out now and has pretty much the same effect that she has here at 9 weeks. This lady, long-term patient, Botox of mine, she's got a midline little cleft here from her corrugator that she kind of, I'm ready to get off Botox and try something different. This is her effect, frontal branch ablation at 8 weeks. She's very pleased. How long it's going to last, I'm not really sure. Another patient, deeper furrows. Slight effect, not quite as much in her. If you look at the angle of her medial brow, maybe she's got more of that oblique component because I only did the frontal branch, may not have got as robust of effect. This is one case that it really just didn't work for me. She really, to me, got 0 effect. This gentleman, he's in the 50 units of Botox for glabellar relaxation club. Even 50 doesn't really get him, so he was interested in trying something new. Modest effect. It's nothing robust, but it's improved. He's happier. He uses much less Botox now to his glabella to get the effect that he wants. 7 weeks out, still early. Same thing here. Nice effect at 5 weeks. Botox basically doesn't work for her. Our best injector is 50 units. It just doesn't do much. She was game to try the GFX. She's very pleased with her effect. Lessons learned so far, it's a safe treatment, it's effective, it does work. Targeting the frontal branch alone, I can expect a 50 to 80% reduction in the glabellar frown. The result's immediate. I might get better results if I target the angular nerve, but just I told myself I'll get comfortable with my first 20 patients before I started venturing out of the temple. The number of lesions, I think, is very likely to be correlated with the longevity of the effect. All those cases were pretty much 1 and 2 lesions apiece, and RF is a painful stimulus. We're still trying to work out what's the best way to keep these patients numb and comfortable. And I think the combination of the anesthetic, the Xanax, and possibly a light pain pill are going to be the best thing. In summary, it's a unique method for reducing glabellar furrows. It's minimally invasive. It's a very rapid learning curve. It's easy to pick up this technique with familiarity of the anatomy. It's still early in development as far as who's the best patient for it, how to do it the best and most efficient way. It's unlikely to replace toxins, but I think it will eventually have a role in the aesthetic procedures of the brow. Other questions: how long will it last? How many ablations should be done at one sitting? What's the best method of anesthesia? What other nerves can be ablated besides the ones in the brow? This is something I've kind of been thinking about. I can't figure out. What about the patient who's 8 months out, 10 months out? They want another procedure. How effective is a second ablation? Are we risking, once that nerve reinnervates, are we risking aberrant innervations to different muscles? I don't know the answer to that question. Is there a role for migraine treatment? I don't know. What are the economics of this in your practice? Again, I think that's something that's yet to be determined. Thank you.
I wanted to give this talk. I really have never given it before quite in this way, to talk about patients that I think are some of the most challenging that we see, and that is the round-faced patient. And I had the experience one time of preparing a facelift talk, and I started pulling some slides on patients with round faces, and I had to admit to myself I couldn't tell the pre-op from the post-op, and it made me think about what I was putting patients through with respect to rejuvenation. So the question comes up: how do we deal with these patients? First of all, what is a round face? And I think there are 2 components. Bill Little has talked a lot about this, and the 2 components being the transverse proportions of the face, or the inversion of the soft tissue cone, the egg foo young and egg foo old concept, and the contour of the facial silhouette, the transition of the OG curve, becomes one of convexity, roundness, or oval shape. The OG, I think, is a great concept of what we're trying to achieve. The round face patient, of course, one where there's more of a convexity, facial fullness, but without that contrast or that movement of the fullness over the malar area into the lower part of the face. Well, why is it important? I think facelifting versus facial contouring, we're moving much more towards trying to adjust proportion in the face. We all know that aging is much more than just getting loose, lax skin and descent of facial fat. So we're talking now about focal fat preservation, and hypertrophy and atrophy all can occur in any given face at any given time. So the bottom line is not everybody's face ages the same or assumes the same morphology. And the round face tends to have the malar mass preserved or even increased in certain patients, whereas in the non-round or not round face, the malar fat or malar mass is deficient. In the round face, the malar definition is more blunted and then becomes convex in the lower face. And skin excess is not a major problem, whereas in the not round face, as we all know, the face becomes a little more flattened and elongated with time, and there's certainly more significant excess in the face. No, this is not a pre and a post-op, but these 2 women are both 67 years old. And as you can see, your approach, of course, would be much different to the woman on the left, who maybe tends to be a little bit more overweight. We're going to want to probably do more fat contouring in the full-face patient, as opposed to the woman on the right, who really requires preservation of every gram of facial fat that she has, or addition of fat, really, in order to achieve rejuvenation. And Rod Rourke and Joel Pesta, I think, have made a great contribution in trying to study these fat compartments of the face, where they exist, and how we should manipulate them. because I think that a lot of facial rejuvenation, and particularly in the round-faced patient, we need to deal with the fat compartments in the lower portion of the face. And clearly the round-faced patient may be round-faced because she's got a wide facial skeleton, she may have mesenteric hypertrophy, but really from a practical standpoint we can't do much about the skeleton, we can't do much about the muscle, so we really have only the fat to deal with at our fingertips. And really this is the kind of patient that I'm talking about here that almost defies description. Everybody knows what we're talking about, but it's a patient with this sort of appearance to her face. And in order to rejuvenate a patient like this, in my opinion, I think we have to somehow deal with the excess fat in the lower portion of her face. Her malar mass is preserved, but she lacks definition and has more of a convexity of the facial silhouette. Now, here she is post-op, where I've tried to reduce the bulk in the lower third of the face, trying to not only lift the jowl, but reduce it in order to give a little bit more of a transition from the upper malar mass to the lower part, and in so doing, I think, move us more towards the Bill Little OG curve. So, how do we do this? The challenges presented in lifting the round face are that to reposition fat to augment the cheek may, in the round-faced patient, actually be counterproductive. If you take this jowl fat and simply lift it into the lower part, it could make the face wider and rounder. And as we mentioned, facial contouring with soft tissue change alone may be inadequate. Scott Bartlett did a nice study where he showed that the facial skeleton actually widens with age, and that's obviously something that we can't really do something or do much about as aesthetic plastic surgeons. In my opinion, I think excision of buccal fat has not been that useful. It's a structure which lies pretty deep, and there are patients, the Korean patient with a very wide face, I think benefits by buccal fat reduction, but by and large it doesn't contribute to rejuvenation of the jowl area, which is really where I think most of the round face patients have too much fat. Structural fat grafting definitely can help by smoothing the nasolabial fold area, which may be exaggerated by preserving cheek fat in the round face patient. But by and large, the workhorse for treatment of this type of patient is either ultrasonic liposuction or standard liposuction. So I want to spend the next few minutes talking about how I've been using UAL in the face for the last 10 years to treat this type of patient. And just a few comments here, of course. Yesterday, I think we talked a lot about facial fat contouring, and I think we can now certainly understand how different surgeons approach facial rejuvenation with techniques that may seem mutually contradictory. That is, either by rejuvenation by removing fat versus rejuvenation by adding fat. And I think we're now at the point where we need to use both techniques. And certainly we all understand that facial fat is a precious commodity. We do not need to over-resect it. And Sid has been pointing out here for a long time that proportion is the most important principle in aesthetic proportion, or in aesthetic facial rejuvenation. But certainly, just as some patients demonstrate a lack of structural facial fat, others have regions where fat exists in excess, and that's what we're talking about here in the round face. So fat injection and UAL are complementary techniques. They're not mutually exclusive. The best candidates for this are the patients who have youthful faces with elastic skin and just excess cheek and submental fat. But also patients that have decreased skin elasticity and excess cheek and submental fat can be treated in this way. And I think you can decrease the length of the incision. In other words, convert patients with conventional facelift incisions to so-called mini facelift or short scar facelifts by decreasing the bulk in this area. Here is the kind of candidate who is ideal for this, the patient who has the full round face. This patient is only 21 years old, but genetically she looks just like both her mother and her father, with excesses of facial fat in the jowl and submental area. And here she is seen post-op at a year. Here's an older patient, who I think can benefit by this, doesn't want a facelift, but by contouring fat in that jowl and submental area and adding a chin implant through a fairly easy technique, we can improve her profile. Why ultrasound? Well, at least in my hands, I think it allows us to sculpt fat more precisely and minimally. And we're talking about removal of a very small amount of facial fat here. We need to avoid producing grooves and furrows and indentations. And I think, we've alluded to this yesterday, how just injecting facial fat or treatment of the subcutaneous plane affects the way the skin looks. And I think what we're doing in this case is we are stimulating the vertical supporting structure of the skin, and we can get a little lifting effect. And Lou showed that 15 or 20 years ago, just by tunnelization of the subcutaneous plane, it demonstrated that there was a lifting effect with removal of no fat whatsoever. Let me just go through the technique here. Of course, the two rules of ultrasonic treatment: we need to always make sure it's a very wet environment and keep the probe moving. We instill the wetting solution, we pre-tunnel, then we apply the ultrasonic energy, we remove the fat, and then assess the tissue. And this is the patient that we're showing in this video here. And you can see where I definitely want to preserve fat over the malar mass. The malar area here, the only place that you can, the malar area is preserved. I'm going to contour fat in the lower part of the face. The only part you can get into trouble there is where I marked, which is where the frontal, or the marginal mandibular branch of the facial nerve is most superficial, crossing the mandibular border, where you can palpate the facial artery, and that's where it is. And as long as you're in the subcutaneous plane, I hand tumesce this. I like to be able to control exactly the amount of tumescent that I put in. Anyway, make a little stab wound in front of the earlobe. If you go behind the earlobe, you'll end up under the platysma, and you can damage the marginal mandibular branch. And I like to pre-tunnel using this little spatulated facial cannula. And here's really what we're talking about. I use the Mentor machine just because I have it and it works, but clearly the best technology available at the moment is Vaser for this. And you can see what this is doing under the skin. So you need to be very careful. I don't use very much ultrasonic energy here. You just need to, and I lower the amount of energy that I'm using to half of what I would use in the body. And then go ahead and treat the area with ultrasound, only until you can slide the probe in and out very easily. Then you're done. Then go in with this little spatulated facial cannula. This one is a 2.8 millimeter one. And again, be very careful, very cautious how you're removing fat. You don't want to over-resect fat, but you want it to be even and smooth, and make sure that it's equal from side to side. I usually treat the right cheek first, or the right jowl area first, then the left jowl area, and then the submental region. So let's kind of run through some patients here. The ideal patient is the youthful face with excessive submental and cheek adipose tissue. Bill has said that some patients are born with jowls and they have them throughout life. That's the ideal patient for this kind of treatment. And here you can see this is not really a round-faced patient, but I remove almost no fat in this patient. Just a little ultrasonic treatment of the jowl area and submental area. And it's the improvement in a patient like this is subtle but definite. And they look like they have just lost a little weight. They look a little more refined, a little bit better proportioning between the malar area and the lower part of the face. Under resect, under treat. Don't be in a situation where you have to go back and re-inject fat. And here you can see, and again, another young girl, 26 years old, just looks a little bit full through the lower cheek and submental area. Treated with UAL. Again, very small amounts of fat removed. Maybe these are patients that can be treated eventually with mesotherapy, but I think these are patients where you want to be able to exactly control the amount of fat that you remove. Now we're moving into a little bit more of a full round-faced patient. Again, a young patient, 30 years old, treated with this technique. And you don't get the crisp, sculpted neck that you can get with open fat removal, but certainly enough improvement. And I think in men, even men up through their 40s, although this is a younger man, but get very, very nice improvement with this technique. Again, I'm not touching the malar area at all. I'm really just treating the jowl and transitioning, feathering down into the submental area and neck. Now, as the patient gets a little older, this woman is actually 40 with a little bit of loose skin. But I think these are patients oftentimes that don't want facelifts, don't need facelifts. And you can see that she's got a little laxity of skin in the neck, but enough improvement here that this can be treated actually with some thermage and get a little tightening. But an excellent candidate for this kind of treatment. Again, not necessarily a round-faced patient, but subtle improvements, again, in this patient with a chin implant to improve the overall proportion and balance from the upper part of the face to the lower one. I think that you can use this to delay more aggressive treatments. This is an interesting patient in that she had completed chemotherapy for leukemia and had been on prednisone and had these depositions of fat probably related to the prednisone. Probably not, she wasn't healthy enough or feeling well enough to undergo more definitive surgical procedure, but we just used UAL in her. She got enough tightening from that procedure alone so that we could delay more definitive treatment later on. And here's this woman was just a very busy CEO of a corporation, didn't have time to undergo anything more definitive. We treated her with UAL in an outpatient treatment weekend type recovery, and then later on she came back and had a mini lift about 8 years later. So you can combine this with conventional treatments, either facelifts or endoscopic brow lifts, and I think it's especially applicable, in the older patient who has the full round face and laser resurfacing. Here's the kind of patient that's difficult, I think, to get a really good result with a conventional facelift, at least in my hands. I think you have to, or it's helpful to, try to deal with the fat in the jowl area. Here she is post-op after treating more aggressive treatment of the jowl and submental region. With that improvement, younger patient, another younger patient with a full lower face, and that is UAL with a little preauricular skin tightening as well. A little older patient, again, these are more conventional patients, but that benefit by combining UAL and mini facelifting. So I think in summary, for this group of patients, the features of the round face, the malar mound volume is good. You don't necessarily want to increase that by bringing jowl fat up over the malar mound. So exactly where I think Bill Little is talking about lifting the jowl works well. Or in my hands, what I do is a low SMAS to lift the jowl, and I don't bring SMAS up over the malar area. They have convexity of the facial silhouette as opposed to the OG curve. And UAL, I think, is effective alone in the younger patient, but combined with short scars of traditional facelifting in the older patient. So the algorithm, when patients have good skin elasticity and prominent cheek and neck fat, use UAL alone. If they have marginal skin elasticity and prominent jowling, then use UAL and a mini facelift. If they have poor skin elasticity and prominent neck and cheek fat, then I'll use UAL with a more traditional facelift approach. Thank you very much.
This talk is going to be complications of fillers, avoidance, and treatment. And again, it is not difficult to avoid complications. To me, it's synonymous with a good night's sleep. But the bottom line is every injectable product is capable of creating a complication or some sort of a reaction. It happens to all of us. But we have to decide, what is it? Is it a true complication or is it a perceived complication? And this is where patient education comes in and making them understand what they're going to be expecting. The perceived complications are what patients will think is a complication, but very much, in fact, a normal part of recovery. Needle marks, bruising, redness, edema, swelling, transient lumpiness, feeling the material, and asymmetry initially, particularly when you're using a hydrophilic hyaluronic acid product. These are normal side effects. True complications are allergic reactions, intermittent reactions, granulomas, vascular occlusion, overcorrection, discoloration, superficial placement, visible material, persistent lumps and infections. In the scheme of things, these are pretty unusual. They're pretty rare. But we can classify dermal filler complications as those that are early and those that are late. So the first key to avoiding any dermal complication is know the material that you're injecting and get very comfortable with it. Know the physiology, how it interacts with the tissue, the reactivity, the absorption, the duration, and whether it's a volumizer or a stimulator. Proper patient selection, always. And proper training and correct placement is essential. I train doctors in many of these techniques. I will not train a non-aesthetic specialist. What is a volumizer? Just that. So collagen, Restylane, Radius, silicone, these are products that add volume, just by virtue of the fact that you're injecting them into areas. The stimulators are those that cause a reactivity and infiltration and reaction within the tissue. And those are stimulators. So Artifil or Articol, which are the polymethyl methacrylate. This is a permanent injectable. Sculptra also creates an interaction with the surrounding tissue. And that is polylactic acid, and that lasts about 2 years, sometimes longer. They're going for longer than that. My feeling about approaching any patient who is a filler patient for the first time is start slow. If they've never had it, they're usually a little bit frightened, a little bit nervous. Start with something that's not going to last as long, either collagen or a hyaluronic acid product. As they become more comfortable with you and with being comfortable of getting injected and want something more lasting, that'll be a natural progression. If they hated the way they looked filled, and I had someone who didn't like the way she looked fuller, I was happy that I used something more temporary. Patient considerations, older patients with very thin skin, you have to be careful what you're using. It's going to be more visible under the skin. Have they had prior treatment with injectables? Are they compatible? Permanent implants, are they going to become more visible, which is my fear as a patient ages? Weather conditions. Believe it or not, there have been some reported cases that if it's very cold outside, there's prolonged swelling with certain types of implants. Correct injection technique and placement of material. I've been at many conferences where my dermatology colleagues say, no, I'm really placing this mid-dermis now in the face. That's really hard to do. In fact, I hope they're not putting it mid-dermally because there are only two exceptions for that. One of them is acne scars, and the other one is for the upper lip lines, and even then you have to be careful. I emulate Restylane fine lines by using a small syringe of Restylane with a 32 gauge needle in upper lip lines. Acne scars, you're going to see just transient blanching and then you disperse the material. Other than that, it is to be avoided at all costs. Again, you don't want to go too deep. You don't want to do an intramuscular injection because when you go too deep within the muscle, the muscular movement will dislocate the material and then you'll have some uncontrollable migration and lumps. All of these have happened. If blanching occurs while you are injecting, withdraw the needle, disperse the needle, and massage it. Do not ice an area where you're seeing blanching because that's going to further constrict and occlude blood vessels. The exception for the blanching is acne scars. It's like in a cardiac arrest, first take your pulse. When you see blanching, you kind of get that feeling too, but usually it just goes away. Gray of the needle should never be visible through the skin since it's going to indicate that the material is being placed too superficially. Acne scars are not mobile, and therefore when you place material superficially, the material will not form superficial granules since it is not moving. There is no great treatment for acne scars. I've run the gamut with lasers, dermabrasions. My favorite is really injecting them with filler because it's the least, it's the most user-friendly, least downtime, and most cost-effective since acne scar injections tend to last. Again, early complications, redness, bruising, you want to ice for that. Edema and swelling. As I'm going to allude to, I think it's really a good idea to keep a bottle of prednisone in your office, 5 milligram pills. If someone doesn't want to have the swelling with hyaluronic acid material, you can give them 20 milligrams of prednisone. That really is all they need. Some people will use it the day before, the morning of, you give it the day after. It is really very helpful, and it's easy because they just need for 2 doses or 2 days that you can give it right to them. Overcorrection is always a problem. Again, I would rather they come back for more, and they that's one of the things when they're getting filler, you're going to need to come back for more. Skin necrosis, again, this is a problem. It's not very common, often with too superficial placement, getting a blood vessel infection, unusual. Embolism and blindness. This was reported with collagen, Zyplas, and glabellar artery many years ago, and there was, I believe, a reported case with Symmetra. Keep the needle moving. When you're injecting viscous material, make sure that it is constantly in motion. If you see, I know it's, with Restylane, if you start to see that blanching and you're concerned about the occlusion, you can just poke a hole and remove the material too. Herpes simplex, when you're getting lips, I don't treat people prophylactically, unlike laser where I used to for injectable filler unless somebody gets them constantly. I don't prophylax. Late complications. Granulomas are also rather unusual. They occur in less than 1% of patients. And they usually occur 6 to 24 months after the injections. They're due to a sudden stimulation of the memory of macrophages. They're not allergic reactions. Once resolved, you can actually give that same implant again. It is not that common. They all do resolve. The key is to truly diagnose a granuloma. If it's 3 weeks after, it's a lump. It's not a granuloma. Late rare complications, lipoatrophy, usually because there's a collection, irregular placement of the material, it should be removed. Ridges in the dermis, usually when the muscle it's from overmoving immediately after injecting, the material tends to move upward from muscle movement. Steroid atrophy from treating lumps. This is a patient of mine who had radius injected into the lips and really gets radius lumps. There are some colleagues who like to inject it in the lips. I've done it twice. I don't like it. And this is someone who had lumps and bumps. This is hard because these are deep, but this is over here. This whole area is a ridge from Sculptra. Sculptra needs to be diluted properly. I agree that if you put it in hot water, it dissolves pretty rapidly as opposed to 3 days. And it needs to be massaged, and the patient has to massage it at home. They cannot leave your office if there is a bump palpable. It has to be fully massaged at the time of injection. I recommend using ultrasound gel to massage the material down. It actually is very helpful. This is, there's a good product. It should never be injected in the tear troughs, and that's radius. So this is a patient who came in. Again, this was done by an internist. And I'm treating her with intralesionals, massage. It's getting a little better, but that last part where you're going to find flatter, whiter bumps, that's going to take time to go away. Immediate period, ice the injected area unless it's a vascular occlusion and blanching. Massage the treated area to smooth out lumps if that's indicated. Most important, inject the correct product at the appropriate layer of the dermis. And this is actually a study that was done by Michael. He was one of the participants, Michael Kane, who admittedly is one of the slowest injectors on the planet, that if you inject too quickly, the speed of injection increases the number of adverse reactions. This was sad news for me because I'm a very fast injector. Significant swelling can occur, like abnormal swelling, usually correlating with higher volumes. Again, this responds beautifully to prednisone. Keep that in your office. You really just need, I keep 5 milligram tablets. I can give them to the patients. I'll give 30 milligrams one day, 20 milligrams the next, and you can just give it to the patients instead of having them have to go to the pharmacy. Superficial deposits, which look like blue bumps, which is one of the reasons I don't use superficial injections of Restylane in the tear troughs. The nice thing about Restylane or any hyaluronic acid is you can do something about it. And you can either easily extrude it by poking a hole in the skin and squeezing it out. It comes right out, even if it's been there for 2 years. Or you can inject hyaluronidase. Again, this is vascular occlusion. Keep nitro paste. This works really well in the immediate period. If you're starting to notice that there's blanching and you're suspecting vascular occlusion, put nitro paste on. It dilates the blood vessels and it works really well. Hyaluronidase, I've used once. It works within a week when you do use it. It enzymatically will dissolve hyaluronic acid fillers. In the old days, they contained thimerosal, which they don't anymore. But there's a different protocol. One of them is using Lambros, 75 units and 1.5 ml of lidocaine, or Vartanian, 20 to 60 units undiluted, 25% reaction rate with that. But it works in a week. And that's really from superficial placement. If you suspect infection, you treat it with an antibiotic. If you suspect viral infection, herpes simplex, you treat that appropriately as well. Granulomas and areas of inflammation respond well to intralesional cortisone. And what you basically do is you start high. You give 10 to 40 milligrams of Kenalog. 5-FU can diminish steroid atrophy. But the bottom line is most of these resolve pretty spontaneously within 2 years. So most complications can be avoided. And the ones that can't be avoided generally can be treated or can actually resolve on their own. Thank you.
I have a few questions before we go to lunch. One is, I noticed on Jeanette, you inject radius intraorally, and you don't use nerve blocks. How do you do that? And have you had any infections with using intraoral radius?
No, I don't use intraorally if someone's had any kind of an implant. If they have a cheek implant, I don't want to use it to introduce infection. I've not had a problem with it. I haven't been doing it that long, but I haven't had a problem thus far. I use a Bexa Luer Lock tip, which is a double tip, and I kind of switch back and forth.
And you use
lidocaine.
for 1.3 cc syringe, you use how much?
0.2%, and I use a 3 cc syringe.
And so you inject into the malar area and orally?
I inject into the buccal area.
Buccal area.
You know, I use hurricane
Okay.
in the entire mucosa, and then I inject above the gum right into the buccal mucosa, so it really is here. I don't go higher than that. I don't, I don't inject it in the teardrop of Restylane. Some people go higher, but I have better ways.
Okay. Alex, you talked about, I love the clinical pearls you had about, injecting deep and using 0.1, because you're right that if you use less than that, even if you inject, you won't get back to the retinal vessel. But why do you go from medial to lateral? I usually go from lateral to medial, staying deep, and I do an antegrade, and I actually use my index finger to massage it. So why do you go from medial to lateral? Is it
Actually, I never thought about that.
it's easier lateral to medial, but
Yeah, well, I'm definitely going to try, but as I go from medial to lateral, I see immediately the response of the amount of pressure that I put on the plunger and the effect that it gives under the skin, because the medial part of the skin is the thinnest. So that gives me some kind of an idea if the patient's skin is responding well and then coming up easily. Probably that's the main reason for me to go from medially from medial to lateral. But I can.
yeah. The other thing is, sometimes when I'm doing tear troughs, if they have malar hyperplasia, which is the triad of a tear trough, sometimes I then will inject some Restylane deep, right? There's a deep fat pad, which I'll talk about. Then you'll actually fully correct that, and especially in the patients with true malar hyperplasia with some atrophy in that area.
Yeah, I've done it too.
Yeah. So, and Farzad, tell us about, is this supposed to be permanent? I know we don't know, but by historical reason, isn't it supposed to be permanently effective in some of these patients, or what's the science behind it outside of what you're doing now?
That's a good question. Jim Newman, who's a facial plastic surgeon in San Mateo, was the one that I went out and watched do this to learn it, and he's got the most experience. I think he's at 80 to 100 patients with this. I reviewed his results with him in Baltimore just a couple months ago, and he is at the point where he's doing pretty much 3 lesions on everybody on both sides. He'll start with the frontal branch first. If they still have a significant amount of activity after that ablation because the result's immediate, he'll then go to the angular branch and do 2 to 3 lesions there. He's seeing return of function at about 8 months, 9 months. You'll start to see return of function, not 100% like it was pre-procedure, but the start of the return. I think it's just like anything else. If you were to cut a nerve that was in the mid-nuclear line, you expect it to come back, and I think it's the same thing. If you run RF energy through it to ablate it, it's going to grow back.
Now, is there a lot of swelling with that procedure? Because the great thing the great thing about Botox is that in contrast to some fillers, they can be out and about after an hour and a half. They can do anything they want. I mean, is there a lot of swelling?
There's a little bit of swelling, and some of it's from the local, and I've tried to minimize how much local I use in the area. There's not much swelling from the procedure itself. The common, if I get a phone call from a patient 2 or 3 days later, I expect them, they're usually calling me about a headache. And they feel a little frothy in that area over the temple where I've put that blunt tip in and run the energy to find the nerve, and then run the energy to ablate it. They're usually having some frothiness and headache. Not in my hands with 16 patients, it hasn't been swelling.
I have 2 questions. One of them is an area which has not been addressed, the vertical upper lip lines, the ones present with motion and without motion, deep and superficial ones. What are your personal choices, Botox injections or fillers for each type? And also, Dr. Graff mentioned that for depressed acne scars, her best treatment is fillers. But some of these patients have deep and dark acne scars. If you fill them, they come out, but they're still dark. So there's no place for, like we were being trained 14 years ago for dermabrasion or lasers. So how do you address deep and depressed and dark acne scars and the vertical lines on the upper lip?
Okay, would you like to take that one?
The acne scars, well, you're right. I'm not a big fan of dermabrasion. I know that there are some who like it. I just don't like what it does to the skin. It just makes it look more scarred and more shiny. I don't think it has a nice natural look to it. However, the discolorations, you're absolutely right. Those should be addressed with IPL before doing the injection, and that tends to respond very nicely. And I would do that before doing the filler.
You can do it at the same time, can't you? Maybe
Yeah, but do the IPL first.
Yeah, that's right. Okay.
And the lip lines?
Oh, the lip lines, vertical radius. How do you? That's volume filling.
I generally do. I don't use a lot of Botox in the vertical lip lines because you have to use a lot. They've never really worked significantly well. They don't last very long when you use it. I have some patients that I've done it on. I do use a lot of Botox in VAOs and other areas. I tend to use Restylane with a 32 gauge needle, and I fill the lines in as best I can. It usually takes a few treatments to do it, and you can get a good result, and it lasts a long time.
Yep, that's true. Yeah, I'm using a small needle, and there you go, very superficial, quite superficial. Yes, one last question.
Hyperpigmentation after injection around the tear trough area. 2 questions. Do you think it's post-inflammatory hyperpigmentation or actually hemosiderin deposition, and how do you treat it?
Hyperpigmentation after injections of hyaluronic acids in the tear trough.
Hypopigmentation?
Hyperpigmentation. What do you think it is? Hemosiderin deposition if you had a lot of bruising from it, or what do you think it is?
Well, I think there's definitely a racial component. That's one thing. Some Middle Eastern people just have pigmentation, and I don't think you can treat it. The thing that you can correct with injection is the shadow, and sometimes the show of superficial vascularization, but I don't think that you can treat the pigment.
Yeah, how do you treat patients that comes in and says, I only get these black eyes, and they're 25?
Well, the best way to start is, as you said, to treat the shadow, because the shadow is one of the reasons that you see such a significant shadow. The other thing is it really depends on the cause of it. There may be some hemosiderin deposition in there, and there just might be some pigment deposition. You can try intense pulse light on that. That might have some help if it is a pigment from hemoglobin or hemosiderin.
Yeah, and the bottom line is it's very difficult to treat the quote-unquote the black-eyed patient. I think shadow correction is probably the best, and then some makeup, because there's nothing, at least to my knowledge, laser, non-surgical, surgical, that really treats that well.
I'm going to be racing through a lot of these slides because I put in a lot of information just so that it would be there as a reference. But this is the reason that we need to have skincare, because this is an alkaline phosphatase stain of aged skin. These are blood vessels in photo-aged skin of a 70-year-old smoker. You can see that flat epidermis. This is the skin of a healthy teenager with this beautiful, beautiful network of blood vessels. So this is one of the reasons that we need to treat our skin from the outside in. There are age-dependent changes that are introduced and induced by many of the things we do. I want to be a bit practical. This is an acronym, PrEP, P-R-E-P-P. This is how you approach any skincare regimen of every single patient. You prepare. You have products that renew and rejuvenate and enhance, and you protect and prevent. So the preparation step is easy. You want to use a gentle pH balanced cleanser. There are plenty on the market. Now, here's something that a lot of people don't know, and this is a new science, but when many people go to the beauty counters and they're asked, well, what should I use in the day, what should I use in the night? Well, the skin operates on circadian rhythm. So in the daytime, you have a higher skin pH. It's on the upper limit of normal, and that's to help protect us from the outside pathogens. We have increased sebum production. Sebum contains vitamin E in it, so it is protective. So everything that is directed in the daytime should be about protection, whether it's antioxidants, whether it's sunblock. At the nighttime, the skin is different. It is of a lower pH. There is an increase in the microcirculation of the skin, so lymphatic drainage. So everything that happens at night is really more intact with renewal. So your AHAs, your peptides, your retinoids will be used at night. So when you remember the skin circadian rhythms, it is really simple to prescribe skincare. The membrane barrier, we need hydration. With overpeeling of the skin, we lose our ceramides, so it's important to make sure that we keep that membrane barrier intact and we use hydration. The daily application of a high, broad sunscreen that covers both UVA and UVB is essential. UVB is represented by the number, and I usually recommend a minimum of 30. In the summertime, when the UVB rays are higher, the sunburn rays, I recommend a higher number, but UVA levels stay constant all year round. So your patients with hyperpigmentation need to wear that sunscreen all year round. And there are some really good ones out there. The latest, Neutrogena makes one that contains Helioplex, which is a stabilized UVA block. Also, L'Oreal Revitalift has Mexeril, which is another polymer that's a stabilized UVA block. The topical vitamins, vitamin A, which are the retinoids, the vitamin E, and the vitamin C. This should be in everybody's skincare regimen. Vitamin A normalizes the skin. It's essential for normal skin development. When it is used topically, it enhances elasticity. It increases collagen bundle and reverses signs of photodamaged skin. It actually works on a molecular level, and that is a measurable effect. These are the prescriptions. You were mentioning Triluma when I came in. It is one of my favorite retinoids to use by prescription. Triluma has a tretinoin in a 0.1%. It has a 4% hydroquinone and a mild hydrocortisone cream to minimize the irritation. There's a synergistic effect. In the wintertime, or in your patients who are darker complected, you have to tell them to use a pea-sized drop on dry skin, distribute that pea over the face, and apply a moisturizer to use it only at night because you don't want them to get irritation. Tretinoin without the hydroquinone is in the other forms. Have them start 3 nights a week, especially in the wintertime, and what they can then do is increase until they're able to, not until they can use it every night. Retinol, there's other non-prescription retinoids. Retinol, retinaldehyde, retinol palmitate. Retinol by far is the gold standard. It is a natural. It is most abundant in normal skin, and its penetration and absorption is wonderful. The only thing is it has to be stable. If your patients are getting irritated from it, if it's in a clear jar, it is not stable. Vitamin E, we make it, but not enough of it. It is an antioxidant. It is wonderfully emollient, and it is fat soluble, so it's important for free radical protection. We make alpha-tocopherol in our sebaceous glands, and that's one of the reasons oily skin seems to age more slowly than dry skin. Vitamin C is both a protector and a rejuvenator, but we don't make vitamin C, so it has to be supplemented orally as well as topically. It's a major antioxidant, anti-inflammatory. It is photoprotective, and we use vitamin C and vitamin E in skincare. If your skincare or your patient is complaining if their skincare product is changing color or starting to smell, they have to stop using it. It inhibits bad enzymes. It also lightens skin. So topical vitamin C is very good to use. The only problem is it's a water-soluble antioxidant, and levels decrease with age. Cigarette smoke decreases vitamin C levels. Cigarette smoke is the most aging thing a patient can do. There's a direct correlation between cigarette smoke and MMP, matrix metalloproteinase 1 levels, an enzyme that degrades collagen. So cigarette smoking will directly cause aging. So that's something they need to stop. Bioavailability, well, wouldn't it be nice if you could find a stable form of it, but the only stable form of vitamin C is in an anhydrous or water-free system. These are serums. Something like Kinarase is an anhydrous. These are very nice formulations, but it is the most stable form of vitamin C. There are studies that show that when you use these two vitamins together, you will enhance the activity and effectiveness of an SPF. So we know that when we use more antioxidants with sunblock, we're getting more protection. So remember PrEP. This is protection and prevention. Use your sunblock and antioxidant in the daytime. More recently, CoQ10 and ID-Benone. These are ubiquinones. ID-Benone is a stabilized form of coenzyme Q10, which is highly unstable. It is in Provage. I know that a lot of people have written in that it's the greatest thing since sliced bread, but it is an antioxidant. And antioxidants, there's no the best one because it depends on the testing that you do. More than one is better to use, but it is a good addition to any kind of a protective regimen. Tissue respiratory factors such as yeast extracts. These enhance the skin's ability to produce ATP. These are in some of the skin vector type of skincare by Estee Lauder. These get into the cell and they stimulate the skin's ability to breathe by producing ATP. So these are good to use in any kind of skincare treatment. And yeast extracts are very, very soothing. I am not as big a fan of alpha hydroxy acids as I am of polyhydroxy acids. These are much larger molecules. They do everything that the AHAs do, except they do it with less irritation because they are larger molecules. So patients who are darker skin toned can use them without fear. Lactobionic gluconolactone, they're very well tolerated and they are far less irritating than the alpha and the beta hydroxys. These are used as exfoliants. Exercise caution with any low pH product. Any product that burns the skin, whether it's SkinCeuticals, Celex C, most of, if not all, the problems that occurred when glycolic acid first came to the market, the complaints were about irritation. So now you cannot find an over-the-counter AHA that is below 3.5 in pH. But chronic use of low pH products will break the skin down because it increases collagenase. Beta-glucans, these are from the cell membranes of yeast. Also, they're found in certain mushroom extracts. They are very good. They're antioxidants. There have been a lot of cancer studies about them. They are immune response modifiers. You may have seen the most common source in yeast and oat, but they do sustain levels of antioxidants in the skin. So if you have someone who is recovering from a laser resurfacing procedure, this is a good thing to add to the armamentarium. So now we come to the natural antioxidants. Every day there seems to be another one discovered. But they're basically plant polyphenols, flavonoids, catechins, carotenoids, procyanidins, and they are classified based on their structure, whether they're monomers, dimers, or oligomers. Flavonoids are one subclass. Now plants, the pigments in plants are their sunblock. They can't move into the shade, so that color is protective. And that's really what the polyphenols are. And they are responsible for the colors that we see in various vegetables. They are very protective. That's why plants also make vitamin C and E. So green tea is a very common one used. Very often, you are going to see it in sunblock. The most active catechin that is found in the green tea leaves are EGCG, which is epigallocatechin 3-gallate, or EGCG. there are nice skin cancer studies of how protective it is. The carotenoids, beta-carotene, lutein, lycopene. These are naturally occurring pigments. That's what gives carrots their orange color. They are very powerful antioxidants, and they have photoprotective effects on fibroblasts. This is the important thing. Lycopene, which by itself is the most powerful and active of all the carotenoids, which is found in tomatoes, does not bioconvert into retinol. Beta-carotene, lutein, and zeaxanthine do. So they're pro-retinols. If your palms turn orange, that is not toxicity, but it does make you see that it does go to the skin. However, when the body needs retinol, they can bioconvert to that. The studies have also shown that when you use them all together, there is a cumulative effect, which is the way all of these work. So a cocktail of antioxidants in the daytime is the way you would want to go. There's grapeseed extract, again, strong free radical scavenging effects, anti-inflammatory, wound healing. Pycnogenol is another one from the French maritime tree. Resveratrol, which is another one. That's the French paradox of antioxidant activity. And soy. There have actually been studies of taking soy orally in that it does help. When you take it orally, over 6 months, there was a diminishing of lines and wrinkles. There's also Johnson & Johnson makes a soy that actually decreases skin discoloration. I would be remiss if I didn't mention the latest one, which is the coffee berry extract. This is a skincare, I think Stiefel has this product, which is called Reveal. 1% coffee berry extract has been found to be extremely powerful as an antioxidant. It is from the coffee plant, it's from the fruit of the plant, and that's not been used yet because it degrades so rapidly that it has never been looked at. But the more powerful an antioxidant, the more quickly it will oxidize. That's how effective it is, and that's why we need to stabilize them. Now, we look at minerals. Minerals are essential. In the skin, they are what activate antioxidant enzymes, and copper plays an important role as wound healing since it is a cofactor in collagen synthesis. Selenium must be in a selenomethionine form in order to penetrate the skin. If it's not, then it treats tinea versicolor, and that's selenium sulfide. But this is a very powerful essential trace element with antioxidant properties, and it activates and produces glutathione peroxidase. Zinc is another essential trace element that is a cofactor for the very powerful SOD, or superoxide dismutase. So these are what you want. Enzymes are far more efficient as antioxidants than vitamins, because vitamins get used up for every free radical they neutralize. So peptides, the future. We have been coming out with some peptides. Peptides are wonderful because they're tiny and very specific. Unlike growth factors, which not only are like putting marbles in your skin because they're giant, but if they do penetrate the skin, such as the TGF-betas and the TGF alphas, you really don't know what they're going to do, because when they turn on a mechanism, they can turn off a bunch of others. Matrixyl is found in the oil of Olay Regenerist products, and this is a lysine-rich pro-collagen analog. It's a 5-amino acid that kind of fools the skin into thinking that it needs to make collagen. And this was actually published in the Journal of Biological Chemistry in 1990, and it does work. It needs to be in a 3 to 4% concentration. Because Procter & Gamble has a patent on its use now, they came up with a different form of it called dermoxyl that just has a different carrying group in it. Argireline is a 10-amino acid peptide that actually inhibits the catecholamines and therefore decreases the movement. It used to be products called Botox or the Botox-like products, and it has to be at a 10% concentration. So anyhow, the summary of this is that we know synergistic use of combinations of topical antioxidants are more effective than single ingredients. PrEP is the way you will approach every single patient, and it always works. P is for a pH-balanced cleanser. Protective antioxidants, protective sun product, protective mineral makeup because it has an SPF, renewal, enhanced prevention. So you renew with retinol products at night with the PHAs, the peptides, and moisture and hydration. And that is the way you go. You'd start with a cleanser, use a retinol on every single patient. Every patient should have sunscreen, antioxidants in the daytime. And that's the best way that you can approach skincare. It's not really difficult when you keep that in mind.
So what do you recommend to your patients, like when they come in? Okay, so you want to protect during the day and renew at night. So what skincare? What are the basics that you tell them? Which ones do you recommend in your practice?
Well, basics. I'm very clear. They have to wash their face twice a day, and they can use any kind of facial cleanser that they want because they're pH balanced, and that's key. So it doesn't strip the skin.
Any over-the-counter basis?
Any over-the-counter, whether it's Oil of Olay, whether it's Dove, those are fine. In the nighttime, I put everyone on a retinoid. They have to be, whether it's retinol or Triluma. If a patient has very dark skin or very dry skin or very sensitive skin, you might want to go with a retinol. If you don't carry one in your own practice, then you can use a retinol that is over-the-counter, such as a Rock retinol or or L'Oreal or whatever retinol that is from a major good company, so that you know the formulation is good. So that's at night. In the daytime, I have them use an SPF. And there's several that I like. One of the ones that I like very much in the summertime is the Neutrogena Helioplex, because that comes with an SPF of 70. Some people like the Estee Lauder sunblock products because of the fact that they have a lot of antioxidants with them. So daytime, they're going to protect their skin. They're going to use an antioxidant after they cleanse. They're going to use a sunblock. And that's when they'll use their Provage. That's when they're going to use those products. You don't want to use an alpha hydroxy acid or an exfoliator in the morning because that's when your skin needs to have that protection. The sebum that is there is needed for protection. And I like to have them use Jane Iredale because that's extra SPF. Especially if they're going out to work, it's much easier for them to go outdoors to touch up their makeup first.
We'll have about 25 minutes, but we could talk about lasers for quite some time. So I'm going to just give you an overview. I'm not going to make that many recommendations about what to buy, but just kind of go through this. And if you have any questions afterwards, I'm very responsive to emails. I am a consultant for Cyton, so anything I say about these type of lasers, please be aware. Let's talk about what's hot. I mean, this is really what the patients come and ask us. So ablative lasers are back. There's no question they went through their day when they weren't really getting the attention, and now they're back again. They're back because of 2 new technologies, fractional ablative and some of the lighter laser peels. So I'm going to talk about this a little bit. I've been doing non-facial things like décolletés for quite some time. It is a great addition to your practice. I'm going to show some slides. If you've never done this before, it's an easy thing to do. Skin tightening is what's super hot. And as I said yesterday, it works a little bit, bottom line, 20 to 30% improvement. Not going to replace surgery yet, but definitely a nice addition to surgery for those patients who really can't have surgery. And the non-minimally invasive body contouring things like UltraShape and liposonics and things like that, and laser liposuction, things to watch out for. These are going to be very exciting when they hit the market. I think it's really going to revolutionize the way we look at things. First device to buy an IPL. Okay, dermatologists will tell you this, and anybody else. That's probably the most useful thing you can buy in your practice. You can do some vascular, you can do some pigment, you can do some skin rejuvenation, and some hair removal. I was never a fan of IPL because I live in Florida, and you have to be aware that on tan patients, you can burn your tan patients. Having said that, we use it all the time. So the newer systems which have integrated cooling are unbelievable. My other recommendation is buy a resurfacing laser if you're a plastic surgeon. The rest we're going to fly through this now. So when we're talking about intense pulse light or broadband light. We're talking about light in the visible spectrum. There are different machines out there from very reputable companies. Some of them have filters like on the left, some have interchangeable handpieces. You use different filters or different handpieces for different clinical applications. This is an example of an IPL used for some hyperpigmentation after an accident. This is an example of IPL used on the hands. Very simple treatment. You get about 50% of the result with the first treatment. On the chest, unbelievable on the décolletés. We have done quite well financially in our practice with treating décolletés. For difficult patients, we'll treat them with a little light laser peel first at the same time. This is another patient. This is 2 treatments around the décolleté. This is 5 treatments over a couple of years. It really significantly improves the décolleté. It is easy, just topical anesthetic. Your techs do this while you're in the operating room. Faces, these are photofacials. You can achieve this with other technology. You can do deep resurfacing, you can do fractional resurfacing, you can use IPL. A lot of different ways you can achieve this result. And this is an example of a patient that I did a light peel on and treated her with IPL. You see significant tightening as well as improvement in the color. In terms of vascular lasers out there, I'm a big fan of 1064. I like 1064 because it gives you pretty deep penetration. You can use it on tan patients and you can use it on darker skin patients. You can do quite a lot of things with this. Most of the newer systems have skin cooling components to it because by cooling the skin, you're protecting the skin. The laser pulse comes down, hits the vascular target, and some of the energy from that can come up and burn the skin. But if you chill the skin, you protect the skin from that thermal damage. This is an example of some of the things you can treat. This is Dr. Kenkel's patient. This is rosacea and port wine stain. These are very small vessels. You can treat telangiectasia, slightly larger vessels. What I like about this wavelength is that this is instant gratification. When you treat this type of lesion or this type of lesion on the patient, it is done immediately. They walk out of your office with no veins, and they're happy to pay you for this. Leg veins, different story. Leg veins are multimodality therapy. You need to look for feeders. You have to look at flow rates. It's much more complicated. It's an adjunct in my practice to sclerotherapy and to endovenous procedures. But don't think that you can use a laser to get rid of all leg veins. Dark circles around the eyes, pull the eyelid down. A lot of times there is a vascular component to this. These are easily treated with one treatment with any of these deeper lasers. That's usually about 100 millisecond pulse width at about 100 joules with the laser that I use, and that's one treatment. It's gone completely. Things like this, veins in the mouth, leaks like this, these vascular malformations. This is one treatment. These are very easy to treat. There's no skin damage at all. This is cake, and this is easy, and the patients are happy. Hair removal, difficult subject because all of these medi-spas all over the place have prices that really you can't afford to beat. So you're treating hair in the growth phase. It's not a usual large part of many plastic surgery practices, but you need multiple sessions for this. You have to treat the hair in the anagen phase. So if typically 20% of your leg hair is in anagen phase, you need at least 5 treatments. We usually treat every 4 to 6 weeks. There's a lot of different lasers out there for hair removal. Ruby is the initial laser. You can use this on light-skinned patients with dark hair. Alexandrite, still made by some very reputable companies. Light-skinned patients with dark hair. As you move to higher wavelengths like a diode, you can use it on darker skin patients. And as you move to 1064, you can use it on tan patients. In my practice, we use 1064 for darker skin patients and tan patients, and we use pulse light for lighter skin patients with dark hair. And a lot of doctors out there now are using combo therapy. They're using pulse light and 1064 on the same day or sequential treatment. Pulse light one time, 1064 the next time. Because as the hair regrows, it's often very fine. So you need to change your settings down the road. So this is what not to do. This is a dark skin patient treated with a poor laser choice, and that's why they have this problem. This patient should be able to get away with anything. This is either too much energy or poor cooling on this patient. So that's what not to do. This is what to do. A couple of treatments. This is with the 1064 system. Easy to treat. Back hair is easy. Just beware of your bodybuilders who are on testosterone therapy. They will regrow their hair, so really be careful. This is a flap that was sent to me by Tony Wolf for a big squamous cell cancer. This is 2 treatments of removing hair on the scalp. So this is what I was talking about yesterday. It's pretty easy to treat. Ingrown hair, pseudofolliculitis on your darker skin patients especially, it will really help their lives out. A lot of darker skin patients get ingrown hairs of their face and neck, so definitely something to have in your practice. I talked a little bit about this holy grail of plastic surgery yesterday, non-surgical skin tightening. You get some collagen shrinkage from this. There's electron micrograph of collagen, and you get fiberglass stimulation, which regrows the skin, and the skin is better and thicker. In theory, it works great. In practicality, it works a little bit and will not replace surgical procedures at this time. The chromophore, or the piece of the tissue that the laser beam is attracted to, is water in this case, and there's a lot of different devices that we have used over the last few years from this. We started with these wavelengths like 1319 and 1450, and we moved to things that go deeper like RF and long pulse infrared treatments like Titan. The first generation, really, the 1319 and the 1450 wavelength, hit the upper dermis, and we use this for things like acne scars. There was a question, well, what do I do for acne scars? I treat them with a 1319 nanometer laser. It's like watching grass grow, but a lot of times you'll get a very good response over time. It'll take you a couple of months to see these type of results. Ritids, not so good results, but inconsistent results. I don't use this technology at all for periocular ritids. We played around with this for skin tightening with very unremarkable results. That's why we went to longer pulse lasers and lasers that went deeper into the skin to treat this. Active acne works wonderfully on active acne, but active acne, as you know, is multimodality therapy needed. Antibiotics for cystic acne and sometimes Levulan. But I like this for my patients with active acne. So I use this particular wavelength now for isolated acne scars and active acne. When I want to go deeper and tighten the skin, I use different technology than these superficial absorptive lasers. I'm into the 2nd generation lasers. We actually have 4 systems in our practice right now, and currently the one we use the most is radio frequency. We have an Accent and we have a Luminous Illuma. I don't find the Luminous works that well. Thermage is another one. They all are radio frequency devices that differ a little bit. The Accent is monopolar and bipolar. Thermage is just monopolar. Cineron is RF plus IR, and the Luminous is vacuum plus RF. So there's a lot of differences between individual systems. They all tighten the skin a little bit. The initial Thermage data was relatively inconsistent. They found that there was 30% responders. That meant that there was 70% non-responders, or 7 out of 10 of my New York patients who live in Boca were complaining to me. So that's not too good. Nowadays, there were initial problems with that initial protocol. It was slow and it hurt, and sometimes you saw some fat loss. The newer protocol, Zelicin came up with this new protocol with a fast tip. It's multiple low energy passes with the Thermage. So with this protocol, the complication rate is very minimal, and the results are very similar. And you saw some tightening. I mean, this is not the same thing that you're going to see with a facelift. But think collagen. When you're doing a facelift, what you're doing is taking skin that has lost its elasticity and moving it to a higher location. So why not after the facelift try to rejuvenate that collagen? Get a better result. And this is a Brian Weisman's photo, seeing some rejuvenation around the periocular area. Cineron is another type of radio frequency device. And the Accent, which we have now, we bought it for cellulite. We're finding that we're using it for skin tightening more than we are for cellulite. And this is with bipolar and unipolar RF. And again, we use it on the abdomen. We have a Luminous Illuma, which is suction, which we have not been very impressed with this. And for fine lines, maybe you can see a little bit of reduction, but we haven't been impressed with this device. We also have a Titan, and we have a Cyton ST. Those are 2 other infrared devices we use for skin tightening. They're both pretty similar. Results from the Titan from Barry DiBernardo were quite good. And think after a tummy tuck or after pregnancy, you might be able to get some tightening with this. This is Barry DiBernardo's picture. And this is a type of, it's an infrared device, so it's a long pulse infrared device, an IPL. Alma makes a similar device. This is right side treated, left side not treated. And this is at 3 treatments at 5 passes per session, 7 years old with Cyton system. Abdomens that I treated with this system, so I know I got these results. This is a little morphing of one of the abdominal treatments that we did with this. So you do get some tightening. The results are more consistent. They're not overwhelming in their response, but they're getting more consistent as time goes by. We bought the Accent for cellulite, and I think it works better for skin tightening, and that's the 3 devices that are out there right now. They find that they all work a little bit. They do tend to recur, but what you're seeing is that as time goes by, technology improves, and we're getting a little bit better and better over the years with these devices. So concluding for skin tightening, there's some tightening, but the results are somewhat inconsistent. And again, as everyone keeps saying over and over again, don't oversell. Under-promise and over-deliver. And think post-facelift and post-abdominoplasty, and we will get some good results. But I think every plastic surgeon should have some sort of ablative system in their practice. And this is where it gets a little confusing, because now we have ablative, and we have fractional, we have ablative fractional, we have non-ablative fractional. See if I can clear this up a little bit. So with ablative resurfacing, you're taking down the skin just as you would with a chemical peel or dermabrasion to a predetermined depth. The CO2 laser was the first laser that we really used for this, and you got ablation and you got some thermal damage. But the problem is, you actually got some good results. You thickened up your epidermis, you thickened up the dermis, and the histology looked great. But in practicality, you got some very good results with this. But you also saw some very bad results from this due to too much thermal damage. You got prolonged redness in some of the patients, you got some hypopigmentation, and in the worst cases, you got hypopigmentation and scarring. So with newer resurfacing technology, I think your safety profile is much better. I'm a big fan of an erbium laser. There are other lasers out there that do some similar things like YSGG, that's the Cutera Pearl, and plasma resurfacing, and also the fractional devices. An erbium laser gives you a lot more water absorption than a CO2 laser does, so you get ablation with very little thermal damage. So it's much more versatile than a carbon dioxide system. It's not just an on-off switch. I use it for light peels, I use it for deep peels, I use it for fractional, and I use it for combined treatments, and that's where we're seeing the most exciting results right now in the combined treatments. So this was the first deep erbium resurfacing I've ever done, and I did him about 7 years ago. I did endobrow on him and a bleph, and I got a pretty good result in 8 months. But he walked into my practice 7 years later, and I didn't Botox him at this time. He probably came in with some Botox, but that's a 7-year result with this. This is with a Cyclone laser, and this is a relatively deep erbium resurfacing. No hypopigmentation, no scarring, and he did quite well at 7 years. And these are the results that I can consistently get with deep erbium resurfacing without hyperpigmentation, without scarring, without hypopigmentation, I'm sorry. Occasionally I have gotten hyperpigmentation when my patients went out in the sun too quickly, but I use Obagi on everybody, and I really cut back my hyperpigmentation rate to almost 0 following strict protocols. But this is about 700 microns resurfacing. That's 7 passes at 100 microns in 1 session. And this is another example of a year post. Another patient, this is actually score works for me, 18 months later. So I can consistently get these type of results with perioral resurfacing at about the 600 to 800 micron range of depth. I talked about this yesterday, some periocular resurfacing. In young patients, I get pretty remarkable results with this. These are micropeels. We do these light resurfacings also with this. This is 60 microns, so they're healed in about 4 days. And I find this very interesting now because now what I do is I do these micropeels and I add ablative fractional at the same time. So now I'm getting better results than this in the same healing period. It seems that the fractional doesn't seem to add to the healing period at all, but adds to the effectiveness of the laser. The Cutera Pearl is a YSGG device, almost the same wavelength as erbium, but a little less. You get a little bit of ablation, and you also get a little bit of thermal damage with this device. And this is an example of Barry DiBernardo's patient after Cutera Pearl, one treatment, and another treatment. I can also get similar types of settings with an erbium laser variable pulse by just setting the laser to those settings. This is with a portrait device. This is plasma resurfacing, nitrogen-based. It's a thermal effect. And this is Dr. Moy's patient, and another one of Dr. Kilmer's patient. So it's a technology that I have no experience with. It's made some significant inroads in the facial plastic surgery community. Many of my colleagues have this device, but I'm still a fan of the erbium laser. I've moved to erbium fractional over the last year or so. What fractional does is it treats a portion of the skin at any one time. That's why it's fractional. The first device out there was the Fraxel device made by Reliant, and this is a non-ablative fractional device, meaning that the holes it creates are made of dead tissue or desiccated tissue, and your body extrudes that tissue over time. This is the histology of this. You can see the control zone of denatured collagen. So with this device, the theory is to get some inflammatory response with minimal downtime and get some rejuvenation. They're on their second turnaround now with this device, the Fraxel 1500. It actually goes a little deeper than the initial device, and they've gotten some pretty good results with it. This is after 5 treatments, but note that these 5 treatments, this is a 6-month result or so because you do 5 treatments spaced about a month apart. So you're not getting very rapid rejuvenation. In my mind, I'd rather do a light erbium peel and have them good in 4 days and have to wait 6 months to have these similar results. So that's why I compare that's 5 Fraxel treatments versus 1 erbium micropeel that I do basically over a weekend healing period. I'd rather choose the latter. The newer fractional devices out there, there's a variety of non-ablative devices from 1440 nanometers to 1540 nanometers, and it gets quite confusing because some are scanned and some are stamped and some have dye and some don't have dye. It gets a little confusing. And there are 2 ablative devices out there, both CO2 and erbium from different companies. The non-ablative devices, there's Fraxel, there's a Palomar, and there's a Cynosure, and these are the 3 companies that make the most of the devices right now. And this is an example of using the fractional Palomar device. This is a stamped device. And this is after the Affirm, which is another fractional device, non-ablative technology. This is ablative fractional. With ablative fractional, they actually create a hole in the tissue. And this is an example of ablative CO2 because you can see there's a little bit of thermal damage in this zone. With an ablative erbium device, it's a cleaner hole with less thermal damage. And this is an example of active FX. This is a fractional CO2 device. Another example of active FX, fractional CO2. I don't have any experience with this device at all. This is Cyclone Pro Fractional. This is the device that I've had the most experience with. And this is my histology. I did this histology. This is a 250 micron spot size. I do have some experience with one of the larger spot sizes that I've been playing around with. You can go pretty deep with this. And this is an example of a patient of mine that just had fractional erbium with no micropeel. This is just fractional erbium at 3 weeks. Now they're really healed up in about, at this settings, 200 microns at 10%. They're healed up in about 1 day. This is another patient of mine. This is 200 microns at 20%. About a 1-day healing period. No, some significant improvement in her cheek riddance. But this is a 20 micron peel. This is non-fractional. So what I'm doing now is I'm doing these 20 micron non-fractional peels and adding fractional to it. So this is an example of a 20 micron peel added to fractional. You can see that you're getting better results than you did with just a micropeel with very minimal downtime. And this is one of my patients that had fractional deep resurfacing followed by fractional. So I use this for my most significant acne scarring patients with some pretty good results now. And this is an example of combination therapy. I'll do fractional, plus I'll do deep. I'll do a little of this and a little of that. And this is with fat grafting as well at the same time, simultaneously. So the questions to answer from this are, what wavelength should we use? We use ablative or non-ablative, and spot size, intensity. It's a very confusing time. I can tell you though, they all work at this point. You will see some good effectiveness with all of these devices. I'm just going to finish up here, and this is the histology comparison. This is erbium, fractional erbium, fractional CO2, and non-ablative. So this is actually, you can compare the different histologies. A couple of words on laser lipolysis, and then we're done. This is a fiber unit used for liposuction. Smart lipo. This is a 1064 device. The laser fiber is very small. There are a couple of companies out there. I've had a little bit of experience with the Cyton device. This is with a 1064 laser. This is the Pro Cyton device. It's at 1064, and I've used it also in 1319. It's not a replacement for liposuction. It's definitely not. Most of the people that I've seen using these devices are moving the fiber so rapidly, they're getting zero contact time between the fiber tip and the fat, and they're doing absolutely nothing. When we play around with this smaller, we're really trying, I played around with it a little bit, and electron micrograph shows that if you do it enough, you're going to see some adipocytes liquefied. But we've seen some results, and we really don't know whether the result, this is my patient at a month, a little bit, I don't really see any significant tightening, and I could probably get the same result with my Vaser device. This is Brian Howell's device. But the one thing I was playing around with this guy that I did Vaser on his flanks, and while I was there, I used a laser fiber using an 18-gauge poke hole, and I tried to etch his abs with it a little bit. And I'm hoping that I can get a little bit more dermal heat generated to create some deeper cuts. But we're still playing with this, and I think there's not significant data on these devices to recommend them wholeheartedly yet. And we're done.
Thank you.
Very good. I'm going to, there's several minor things that we can do as we are making incisions on the scalp that can help us a lot to minimize hair loss, and we're going to go over that. And first of all, I have nothing to disclose. Here are some examples of the type of cases that I see frequently in my practice. And the sad part about it is a lot of these are totally preventable. And here's an example of a patient who had a couple of facelifts, or perhaps a coronal forehead lift and then a facelift. And again, this could have been prevented, and this as well. And we're going to go over some details of how to prevent that. This patient came to me and said, Dr. Pereira, every time I have several facelifts, and every time I have a facelift, my face becomes larger. And, well, we know why. It's not that you're going to enlarge the hairline is being displaced posteriorly and make the face look larger. Typically, this is the traditional incision we're all trained to do, and of course, there's time we can remove a little triangular segment from there to minimize the elevation, but nevertheless, with that type of incision, there's always a displacement. We know we can correct these problems, and there's several articles from 1998, 2003, and 2004, and this is an example of a patient and how we correct this. We're using follicular unit grafts, and in a single session, we can correct this in a way that looks quite natural, as you can see in the next one here. Not the direction of hair, the direction of hair growth, not the absence of scarring in the boundaries of the restored hair. This is done in a single session. Posterior auricular or step deformity from a facelift can be corrected easily in a single session. The elongated forehead from coronal forehead lifts, we can very successfully correct that. That's 2 years follow-up. The loss of the temple from those incisions. We're going to go over the details of how to prevent this in a few moments. And this type of scar that can result from endoscopic forehead lift, you can also cover it nicely with grafts. Prevention is better, so that's what we want to talk about. And I'm going to break it down in 2 segments. One on improving the placement of the incisions, and secondly, the improving of our technique of scalp incisions. As far as improving the placement of the incisions, what I like to do is make an incision that goes hugging the sideburn, just below the sideburn, the superior auricular retrotracheal, in the posterior of the concha and along the posterior hairline, but inside of the hairline. This way, all of the skin that's removed is the skin with no hair in it. You don't have to worry about you can go in any vector or any direction without fear of displacing the hairline. Here's an example. On this patient, I did a facelift, a coronal forehead lift, open lower blepharoplasty, and this is the outline of my incisions. And I will explain shortly why that incision, the temple, is in that of that configuration. This is before and after. This is a 2-year follow-up. The side view, 2-year follow-up. Now we get closer to look at the incisions. Look at the fact that there's complete preservation of the sideburn, and then I swing my incision just in front of the sideburn, as you see by the outline of the yellow lines there. And that way, I can hide the scar a lot better. I will go about in more details on how I make this incision, but orienting it in this direction I think helps a lot. Notice in the crown area, the coronal area, how also parting the hair at the scar, and you can hardly see any scarring. Now the other side, notice the complete preservation of hair. I was joking yesterday, I'm the protector of hair, so I want to give you some personal wisdom that work for me. And using the top. Another example, a before and 2-year follow-up. I like coronal forehead lifts, unless the patient has a large forehead, we do something different, as I will show. And notice that, in fact, I can even bring down in the caudal direction, the sideburn. I can induce a little bit of countertraction, and by countertraction bring down the sideburn as opposed to any displacement. So not only preserving it, but also we can pull it down a little bit. One last example. Actually, there's going to be one more after this. The incisions. Oh, sorry about that. Well, take a look at this one before, and this is a 6-month follow-up. It's an early follow-up, which is again, I want you to see how the area of the incisions look. Yesterday there was some, on this patient what I did is the incision along that orientation that you see with the yellow lines. And yesterday there was a question about, on one of the panels, about if the incision is made anterior to the hairline, that sometimes it is visible and detectable, and I totally agree, and I try to avoid that. And what I do in those cases, when I'm not doing a forehead lift, I'll make my incision going like this. So I can advance this like this. This way I can avoid, it's only a very short distance that it goes vertically into the temporal hairline and then swings posteriorly and around. That way, eliminate that bulge that can occur as we are doing the facelifting without having the scar in the front. And here's where the incision was made, parting the hair exactly on the scar. And on the top, same thing. You can barely tell the scar. Here on the left side, on the right side, you can see also where the incisions were made, and along the temple. How can we improve the technique for scalp incisions? First of all, think of the hair follicle level. Think of the anatomy of the hair follicle. Many times we're thinking about the main objective and don't really think about the hair follicles themselves. Use magnification at the time of incising the scalp. Avoid whenever possible incising parallel to the direction of hair growth. That is, avoid vertical incisions on the temple. I will elaborate on that in a few moments. Incise whenever possible perpendicular to the direction of hair growth. Curvilinear I think is better than zigzag. Incise parallel to the hair shafts, leaving extra roots at the closure might help. Slight beveling might help. I say slight, and I will elaborate more on that. Avoiding damage to hair roots when undermining. Don't go too shallow when subcutaneously undermining scalp. Avoid tension at the closure. They are simple principles, and they work. We just need to keep them in mind. Hair follicle, take a look at the anatomy. They come in groups in follicular units of 1, 2, 3, or 4 hair. There's a 2 hair follicular unit here where we can see the 2 follicles, sebaceous glands, pilorectal muscle. The important part of it is to remember where the vital part of the follicle is. And here are some actual follicular unit grafts. Notice their integrity. And using magnification will help you to see what you need to see. Avoid, whenever possible, incising parallel to the direction of hair growth. If you notice, all of these patients have their incisions were made parallel to the direction of hair growth. When you do that, the scar tends to not only widen, but the hair tends to grow apart from the scar. Notice in that one on the far left how it's so obvious the hair is going in opposite directions. I have noticed over the years, seeing many patients after hair transplantation, when I make the incision perpendicular to the direction of hair growth, the scar tends to heal in a way that is so very thin. This is actually a pretty average scar. There's much better than that. You can look at this one. You can barely tell the patient going for a secondary procedure. You can barely see where I made the incision the previous time. No separation, and the hair does not grow in opposite directions. Another example, close up. Another example, believe it or not, he has the secondary case, there's an incision, there's a heel scar in the middle of that segment right there. And you can see how it heals very nicely when you go perpendicular. But how can we incise perpendicular to the direction of hair growth in our aesthetic or reconstructive cases? Often it is not possible to cut perpendicular. However, if you just incise obliquely, just at least avoid going parallel to the direction of growth. That will help a lot. For example, here, that's why I made the incision in the configuration you saw there. Because this way, the hair is actually, I'm making the incision in an oblique direction, not exactly perpendicular, but oblique. This patient, what happened? Look at the direction of his hair, and the direction of that incision. That scar is parallel to them. But if you make an incision like this, you're going to be going perpendicular in many areas, and in other ones at least oblique. And I know it's easy to say this in retrospect, and sometimes you have to make an incision, or you have to make them, but keeping this in mind will help a lot, minimize problems. Here too, if we could make the incision, if it was possible to make the incision farther posteriorly, make the incision there, then we're going also in many points perpendicular or at least oblique. Here, this was a skin excision, a skin lesion excision on this patient, and if that could have been done, maybe if you took serial excision, that's fine, but just go perpendicular, and that would camouflage a lot better, and you would not have the widening and the hair growing up two directions. What about here? Well, you could go posterior for the reason we mentioned. That way you're going, breaking down. You're not going parallel, but perpendicular or oblique. Or you could do a hairline incision. Hairline incisions, of course, make her a little bit nervous, and me too, but I try to avoid. But in some cases, it can help, and we'll show that in a little bit. This patient, perhaps there was some undermining a little too close to the bulbs, or maybe tension, too much tension was applied. This is sad, but this could have been probably prevented by making an incision such as this one. Or this patient, an incision like that would be very helpful, or it could have been a hairline incision. Of course, he could have had an endoscopic forehead lift as well. In this case, simply making an incision like this could prevent completely that problem altogether. What about this? One of the worst nightmares of a plastic surgeon, and this was done by a very reputable surgeon in Houston, and what went wrong here? If you notice, a lot of the alopecia she has is posterior to the coronal incision, so in a non-undermined area. The undermined area actually is fading better on her. I told this lady who was in tears in my office, I told, well, use Rogaine spray, come back in 6 months. I suspect a lot of this is tillage in effluvium. And she's, Dr. Barry, you can't send me home like this, and please, we should not do anything. Come back in 6 months, we'll talk again. So she went back home, came back in 6 months, and look what we have. So there's a much smaller area now that we're going to be grafting. A lot of it grew back. Take a look at this other view all by itself. Rogaine probably didn't do much, but at least make me feel like we're doing something. And so now we have a lot less work to do on her. We're going to do the sideburns at some point, but it'll be a lot more limited and a lot more appropriate to do it at this point. Now, making incisions parallel to the direction of the hair in the scalp. I know it sounds confusing because I'm saying parallel. Don't incise parallel to the direction of hair growth, but you want to incise parallel to the direction of the hair shafts. This way you can minimize collateral damage of the follicles as you're incising the scalp. As you see in this illustration, actually was a homemade illustration, as you can see, but I think the point comes across. You want to incise parallel so that when you close, you won't have a gap in between. And you can bevel slightly, and I said slightly because if you bevel too much, you're going to have ingrown hairs. But if you bevel slightly like that, you can have a little more hairs, some hairs growing from the scar. Now, you don't want to bevel on the unfavorable direction, and with that I mean you don't want to close without bulbs. And you see the segment here, there's no bulbs in that lower segment, so when you close that, of course, you're going to have predictably at least a wide scar, and you might, if it stretches, you're going to have even wider alopecia there. And the undermining, if you go beyond a little bit, too much, I think 10 degrees or 15 degrees is appropriate. If you go more than that, you might have a problem with ingrown hairs and cysts. There's a happy medium as to how much you can bevel, only very slightly. An example of a patient's coronal forehead lift, to give you some thoughts about how I view this, how I do this. I'm making an incision that's leaving a little bit of extra follicles there on my the posterior side of the closure. This way, I'm going to have some hairs grow through the scar. I'm going to, this is a subgaleal dissection, and then I am using a Proline suture to be a Proline to do some suspension of galea to deep temple fascia. Of course, there's many other choices, but this is what I normally use myself. And this allows me to suspend the flap in a way that there's no tension whatsoever, and I exercise minimally the scalp. And I should say this, you can see some beveling here. This is probably about the maximum leveling I would do, beveling that I would do. And let me suggest that the beveling should be ideally just on one side or the other. Don't try to do it on both sides, because then when you're trying to close, you don't have like a groove that doesn't seem to come together well. So the bevel that you do it probably better that you do it in the posterior incision, or in the first incision you made, and when you excise. You can go as parallel as possible, but I mean, if you have a slight bevel in the favorable direction, that's fine. But don't try to bevel too much, because then you have a little groove on your closure. And on this patient, I did not connect the two incisions, although if it's going to help to drape better the scalp and the skin, I have no hesitation in connecting the incisions. And here you can see it's only a few months post-op, but you can see there's actually hair growing through the scar. This is a patient at 2 weeks post-op, and here she's at a year post-op. Look at a close-up, right on the scar, right at the scar. You can see hair growing from and through the scar. And this is so very important, and it's quite predictable. I can show you case after case. Of course, once in a while I have one that's a little wider than I want it to be, but most of the time they are quite good, quite narrow. You can barely find them. We'll have little surprises every now and then, but for the most part, they are very, they are this good, most of them. This patient wanted to have a facelift, forehead lift, blepharoplasty, and I told her, well, do you want to have a larger forehead or a smaller forehead? Of course, she said, I want like a smaller forehead. So, and this is the case in which I would do a hairline incision and a subcutaneous forehead lift. One of our colleagues, Harlan Pollock in Dallas, has been doing a lot of the subcutaneous forehead lifts, and I tell you, they're very good procedures, and the only place where you have to be careful is around the corners, in the corners of the frontotemporal recession area, is where you might have a little bit of ischemia in some cases. Try to dissect your flap in a way that is a little bit thick. Subcutaneous dissection. You try to make it on the thick side. Even if you pick up a little bit of frontalis muscle, that's okay. Well, here's the patient early post-op and 2 years post-op. Look at the hairline, and you still see a little bit of scarring, but there is some hair growing out of the scar, and if you want more camouflaging, I can always add some grafts. Look at a close-up. Actually, in a moment, we'll close up with that sideburn. And there's definitely, if you are critical, without even not critical, there's definitely a scar in a lot of the cases. But if in most of these patients, it doesn't seem to be a problem. And if it is, you can always graft them. I have the plan B, grafting. Someone was asking the other day, and it was a very good question, about people that have very heavy and deep creases horizontally on the forehead with a lot of heaviness, thick skin. On those cases, those are particularly good to do them subcutaneously. I think it's a great advantage to doing that one. This gentleman, we did the incision like this, and even though you can see, look on the side, I'm going subcutaneously in the area where there is hair. You just have to be very careful to leave that area go thick, and that area does no problem at all. It looks a little bit better. Get rid of that heaviness of the forehead. And then plan B, of course, follicular unit grafts. When you have the scar that the patient is complaining about, you can always hide it with grafts. In summary, for the correction of glaring alopecia, the use of follicular unit mini and micro mini grafts are safe and predictable. For the prevention of iatrogenic alopecias, as we outlined, improve the placement of incisions, thin follicular anatomy level, use magnification, avoid whenever possible going parallel to the direction of hair growth. Incise perpendicular to the direction of hair growth. Incise parallel to the hair shafts. Avoid damaging the roots when you undermine, and avoid tension. And thank you very much.